Welcome everyone to CSCLA's Health Equity Summit. My name is Mayra Serrano, my pronouns are she, ella, and I will be your host for the next 2 days. We are very excited to bring you an incredible series of presentations led by national experts in public health, behavioral health, and oncology who will shine a light on intersectionality in cancer care. So today we will be hearing from a keynote from Bill Kavanagh, licensed clinical social worker and author of Keep Your Fork, Something Sweet is Coming, as well as CE credit presentation from Dr. Jennifer Kelly, past president of the American Psychological Association and director of the Atlanta Center for Behavioral Medicine. Dr. Shannon Cava with Cancer Support Community Los Angeles, and Dr. Arash Asher, Director of Cancer Survivorship and Rehabilitation at Cedars-Sinai Cancer Center. There will also be a roundtable discussion this afternoon featuring Dr. Caryn Whitacre with the LA LGBT Center, Rhonda Smith with California Black Health Network, Sylvia Ferullo Lopez, formerly with UCLA Johnson Comprehensive Cancer Center, Dr. Shannon Cava from Cancer Support Community Los Angeles, and Dr. Ghecemy Lopez with USC Norris Comprehensive Cancer Center. And now I'd like to introduce Julia Forth, CEO of Cancer Support Community Los Angeles, who will tell you a little bit more about CSCLA and the drive behind today's Health Equity Summit. Welcome, Julia.
Thank you, Mayra. We're so thrilled to have you with us at this event this year again. As Mayra said, I'm Julia Forth. I'm the CEO at Cancer Support Community Los Angeles. My pronouns are she and her. And I am absolutely thrilled to welcome you here today to the first day of our 2-day Health Equity Summit entitled Mental Health and Quality Cancer Care. Before we get started, I'd like to thank our generous sponsors of this 2-day event. Thank you to Kite, a Gilead company, Grow at Annenberg, UCLA Health Johnson Comprehensive Cancer Center, Walgreens, Cedars-Sinai Cancer, and CGen. Thank you all so much for your support. The Cancer Support Community Los Angeles provides free of charge psychosocial support. And you see here on this slide some of the many things that we do. We provide support groups and counseling, child, teen, and family programs, healthy lifestyle classes, education and social programs, and research and advocacy. And everything we do here is free of charge. Before we really get started, I would like to invite you to look at this video. Thank you.
Our immense thanks to Cancer Support Community. We know that your motto is, so no one faces cancer alone. Boy, do I know what you mean by that.
Being diagnosed with cancer is one of the most difficult things that a person and their family can go through. The spirit of the mission of Cancer Support Community is that no one should face cancer alone.
When you come through the doors here, it is the most welcoming setting. It's like coming in to a friend's home. And you don't have a feeling that you're going someplace because you're sick. You're going someplace to be with your friends. And that's what it's all about.
My father's name was Harold Benjamin, and he was the founder, along with my mother, Harriet Benjamin, of the Cancer Support Community, previously called the Wellness Community. Mom got cancer, and they realized that actually going to support groups made such a difference in her recovery. So my father decided that he would create this organization that would really make a difference in the lives of people with cancer and their loved ones. Gilda Radner came to the organization. She was so excited about how this changed her life. When Gilda passed, Gene Wilder and a woman by the name of Joanna Bull decided to start Gilda's Club in New York City. Several years ago, the Wellness Community and Gilda's Club joined forces. Several years ago, the
We are a community, and we sustain each other through community. Aside from the services that we give, this is a very important gathering place of hope and support for people.
We laugh a lot in the groups, we cry a lot in the groups. I've made incredible lifelong friends.
I did not know that I was going to live. And I met someone in the group who had been alive for 7 years. Same tumor grade, same location, and he'd been alive for 7 years and had 2 little kids. And I needed the imagination to know that I could survive because I was so certain I wasn't going to.
When I got the news, I think I was numb, and it got really challenging having to break the news to my family because I didn't know how they would take it.
Until we are able to get rid of this disease once and for all, it's nice to know there's a lot of support to help you get through it.
The people that I've met here, I will be friends with for the rest of my life. The things that you can talk about are very personal. It's a safe place. When you get in a group, you realize that the problems really aren't that bad. I would not be here today if it wasn't for CSC.
We had cancer. It is true that he was the one who was having the treatment and the existential experience. But in my way, I did too.
I finally broke down and decided to come into a walking group. You can't talk to your own friends in the same way because they really don't understand. I need as much help as Linda in a different way. That's all. Friends in the same way.
I passionately believe that the cure to cancer is not just the medications and the treatment that they give you. And what we found in the support center here is this amazing experience of being able to come here, find all those other things that make it a holistic treatment.
We have 5 pillars of support: groups and counseling, healthy lifestyle classes, educational workshops, social activities, and child, teen, and family programs. All of those pillars work together to create a holistic way of supporting not just the patient, but the family members.
They have calendars that show all the events and classes here. I've taken advantage of the group therapy, one-on-one, yoga, the lunch and learn workshops, educational things here.
No matter how I'm feeling, I pretty much always drag myself on Wednesdays to the writing group. It's a really amazing, supportive community, and it's really neat because it's one of the groups here at the Benjamin Center that can be combined of both caregivers and patients, which has really helped me to understand my partner's perspective through this, hearing some of the caregivers writing.
I walk through these doors and there's Zumba music dancing and people smiling and having fun.
I have discovered the celebration circle. That's a wonderful time just to get together and think about the good things that are going on in your life and to express gratitude and not so much dealing with the cancer all the time. And it's a time to sort of fellowship over good food and good conversation and really having a time of just celebrating the life that we have. Good conversation and really having a time to just celebrate.
I think that once people find out about this community, I'm hoping that they will be generous with their donation because everything for the patients here, for the families, is free. And we depend on the generosity of people who have the means to give back.
What you do more than any organization in the world is you give a sense of hope. What you do more than any organization, even if it's just one more day, one more week, one more month.
We really appreciate your donations. We appreciate your concern and commitment to this organization.
I think that's the true definition of love, when you can love someone or do something for someone that you don't know. Thank you.
I just want to say thank you because it has given me like a family, and being able to connect and meet such amazing people like that in this space is just such a gift. Like you're really giving people a gift by your donations.
It's just helpful so I know, like,
Now that I've gotten through what I hope is the worst of it, I can look back and say that the cancer support community was one of the joys that this experience has brought to my life. So thank you for allowing me to have that experience, for giving me another place I can call home.
Welcome back. It is my pleasure to introduce our first keynote speaker of the summit today, Bill Kavanagh. Bill Kavanagh is a licensed marriage and family therapist specializing in cancer, addiction, and LGBTQ issues. Bill left his career as an entertainment producer when he was abruptly diagnosed with stage 4 lymphoma. That diagnosis changed his world and his purpose. He recognized the importance of the lessons he learned through his cancer journey, and he refocused his new future into helping others. Bill currently has a private practice in Palm Springs, California. He is a part-time counselor for LGBTQ therapy space, and he is a group facilitator for Cancer Support Community Los Angeles. Bill also worked for 5 years as an addiction specialist with the Betty Ford Center. He is currently in the publishing process for his book titled Keep Your Fork, Something Sweet is Coming, which will be released in April of 2023. We all can't wait to see that book, Bill. Welcome, Bill Kavanagh.
Thank you so very much, Julia. And I think you just gave my whole presentation for me. Before I start, I want to thank you, Julia. I only wish everyone had the opportunity to have a boss like you. You're truly a friend and you're always there for all of us. And so publicly, I want to thank you. And I also want to thank Shannon and Kelly and Beth and the entire team that has put this summit together. I know how much work it is to put something like this together, and I hope everybody out there gets something from what they've done. Welcome to all of you, and thank you so much for joining us. Okay, now let's get back to me, okay? A big part of my presentation is, as Julia said, about my own personal journey after having stage 4 cancer. And when I talk about cancer, I want to make sure that I'm including all illness. Cancer is just kind of a word that represents any threatening illness that hits anyone. There's a lot of important information that we have about treatment and about the disease and about mental health of people going through it. But one huge part that's often forgotten is the journey after cancer. And I'm going to, when we come out on the other side, very often we're told to be so happy. You know, so many other people didn't survive. Yay for you, you've gotten through cancer. But why did I survive? That was a huge question for me, and I was determined to find the answer. Most of us are familiar with Viktor Frankl's Man's Search for Meaning. That was a huge first step for me. When I read that book, I realized that if he could get through that, anyone could get through anything in life. But yet, I want to make sure that and I know that not everyone goes through the existential part of now what? Why did this happen? However, the journey itself is a trauma. Linda Walters has this great quote: everything changes with cancer, everything. Life will never be the same again. Even in the smallest of levels, something will forever be different. There's no going back to who you once were, so embrace it and grow from it and with it. Find the new you in the new space and make it wonderful. For many people, including me, the biggest part of the trauma is that day of diagnosis when you hear the C word. And for me, it just happened to be Christmas Eve. I was sitting in the oncologist's office and he said he had some bad news. He was sorry to tell me that I had stage 4 lymphoma. Well, the first thing that I said to him was, gee, I'm sorry I didn't get you anything for Christmas. But then immediately what came to my mind, and I said to him, was, if I've learned anything in life, it's that the more difficult our challenge, the greater the reward at the end. And so I was excited to see what the reward might be. Little did I have any idea of how great it would be. But I looked up and I saw that the doctor was crying. And he said, so many people do discover that if they choose to, but I've never heard anyone say it on the day of diagnosis, which made me even more hopeful that someday that hope was going to be there. Each patient goes through the healing and the physically in a different way. But just like any trauma, there is a period of PTSD that we have to go through. If you saw in the video that we just played, there's a beautiful wall of butterflies in the yoga studio at Cancer Support Community. There's a reason that they're there. And when I used to give tours of the facility, this was my favorite part to end with. Each one of the butterflies is preserved in a small glass box. They're all from the National Butterfly Preserve, and they're sold to raise money for the preservation of other butterflies. So we didn't kill them just to hang them on a pretty wall, okay? I want to make sure that these butterflies were there. They're there to help other butterflies. But there's a reason that we have them displayed there. A caterpillar goes into the cocoon thinking it could be the end of its life, just like a person with any major illness. And yet, sometimes they emerge so much more beautiful on the other side. The average lifespan of a butterfly in Southern California is only 2 weeks, except for the monarchs who fly away. But for the average butterfly, it's 2 weeks. So I always ask to the people who are going through their orientations, if you found out you only had 2 weeks to live, what would you do with that time? The only thing the butterfly knows how to do is to stop and smell the flowers. Once they come out of the cocoon, they don't struggle with what to do with their lives or finding meaning or feeling shame or guilt. They have no concept of suffering. However, I have to add that I've never had a butterfly as a private client, so I can't exactly speak firsthand, but my guess is they don't struggle. They only appreciate and enjoy life. They appreciate each moment. So if there's anything we learn, it's to appreciate each moment. But it's a blessing and a curse that we humans try to find meaning in our struggles. Just like the butterflies, our purpose is truly just to be who we are. Let our colors shine, although it's not always easy to find the colors. Sometimes, and many times for many of us, going through cancer, we become comfortable in our discomfort. It's similar to why someone may not leave an addiction or a toxic position at work or an abusive partner, because not leaving protects us from the fear of the unknown. It shields us from those horrible 2 words of now what. I know it sounds incredibly odd to say that when I was going through chemotherapy, I became very comfortable in my painful routine. I knew that I'd feel healthy for about 1 day after the treatments, and then I'd crash and be in bed and exhausted for a couple of days, then sick for a day, and oftentimes even hospitalized during that period. But the routine became predictably comfortable. I kind of became lazy in knowing that I was going to be able to just lay in bed for a while. And after several months of that routine, I was sad to leave the excuse to be lazy. I didn't want to return to the world of uncertainty, much less unemployment. The pain was more worth it. Cancer was easier than now what? And I'll repeat that sentence because it's so important for what I'm talking about today, is that cancer, for me, was easier than the now what afterwards. As Julia said, I'd been in the world of entertainment for my entire career, but it felt so shallow to go back to that. That didn't seem important to me anymore. So for my time during cancer, I was perfectly happy being in the skillet, just snuggled up against the bacon and convinced myself that life was fine. But fortunately for my future, the fire was extinguished and I was forced out of that frying pan. And for me, the worst was yet to come. I had no preparation for the depression that was to follow that good news. There was one day in particular that I just went to the beach and cried and called my sister. I said, what is it I'm supposed to do to now just get on with my life? And that was when she said to me, I think you need to start helping other people. Stop thinking about yourself and start thinking about others. A normal person will often say to a cancer survivor, I'm so happy now you can get back to normal. It's well-intentioned, and they don't understand that there is no normal. The new normal is completely unknown. A lot of the processing that goes through someone who had cancer, many people, is why did this happen to me? Why did I survive when cancer kills so many? And these are often questions that are very, very valuable in the therapy process. What was this meant to teach me? Again, so many great existential questions. What will my life be like now? And most importantly, what did I learn? First and foremost, I want to say that I'm absolutely not here to say that every patient should just get over it and learn these things, but instead to enjoy the process of going through these questions. You can't ignore what you've been through. It's a trauma that you have to process just like any other PTSD. And that's why there's so many great support groups like Cancer Support Community. To be with other people who are processing it is so important. Healing through PTSD, as we all know, begins with talking about it. It begins with allowing the thoughts. And one of the first thoughts that we need to learn to talk about is grief. Grieving is an absolute necessary part of any tragedy. Crying allows us to focus on what we love and what we'll get through this with. But there's many levels of grief with cancer. One of them is the loss of our normal daily innocence. Of course, no cancer person ever worries that it's coming back. Of course not. That's the loss of the normal daily innocence, is that fear. There's the loss of life as we knew it before. The loss of some relationships. Many of us had friends who disappeared because they didn't know how to deal with cancer. And I don't know whether that's okay or not, but people have to deal with things as they do it. So we lose a lot of the people in our lives because of that. Oftentimes there's loss of a body part. We do have to grieve that. Loss of our identity. Am I now a cancer survivor? And is that a positive or a negative in my mind? Loss of confidence. And Elizabeth Harper Neild is a wonderful life coach who says that through any grief, the number one thing we have to always grieve is the loss of our assumed future. In any type of grief, our future isn't going to be what we thought it was. It takes a long time to process and sit through all the pain and grief. But the beautiful part of processing is the discovery of hope. You can turn grief into glory. Your love, your strength, and your hope are in your soul. Oh, they are there. This still hits me. They were given to you at birth. Don't ever lose confidence in them. Don't let your mind or another person steal them from you. Sometimes it is our own brain that convinces itself that we no longer have hope or love. Hope and love are always there. Hope and love are always there. So I just want to briefly go back to my cancer journey. Going through the treatments for cancer, all the chemotherapy and all of that was the easy part for me. As I said, I just did what the doctors instructed. But because I was in entertainment and because humor means so much to me, I was determined to make it fun. So I had a long list of friends who wanted to take me to chemotherapy. So I made some requirements that if they took me to chemotherapy, they had to wear a costume and they had to perform for the nurses. This is two examples. This is chemo Kristen and caring Caryn. They were two of the people who took me to chemo. They were both people that I had worked with at Disney. And so they knew about entertainment, and they were very good at making all the nurses laugh. And we had so much fun that I would forget about what it was that was being pumped into my blood, and instead just laugh with my friends as we were going through it. One day, one of my friends who was with me, she took my phone and she said, "I'm going to take your picture, and I want you to look as sad as you possibly can so we can post on Facebook that this poor soul is going through cancer. So look really, really sad." So she took this picture of me. As much as it makes me cry, it still makes me laugh, because as soon as she took that picture and we looked at it, we were cracking up laughing so hard that I did it. I looked as sad as I possibly could. And while we were laughing, one of the nurses came into the room and she said, "What are the other patients going to think when they hear you in here laughing?" And my friend said, "They're going to think that some people laugh no matter what. Some people laugh no matter what." Darlene Hunt was a wonderful woman who produced a TV show called The Big C. And it was comedy of going through cancer. And she interviewed me for a lot of my stories and put a lot of these stories in the show. And I applaud her so much. Again, we can laugh sometimes no matter what. But then, as I've been talking about, one day the fun was over. And I was determined to find what was going to be in my future. When life hands you a lemon, why make something as boring as lemonade? I was convinced that I was going to find a reason for this, just like the day of diagnosis when I told the doctor. It was kind of incredible synchronicity that exactly at that time, a man named Bill Aaron came to me and asked if he could interview me about my cancer journey for a photography book he was creating about cancer survivors. Eventually, he asked me if I'd write the stories for him for his 120 participants in the book. The book is about people whose life thrived because of having had cancer, what they learned and what their journey was, and how they came out better on the other side. One of the things that I like to suggest to my clients who are going through something like this is that you'll never quite, it's all about the exploration. You'll never quite know the answer, but listen for the 4 S's, the signs, the signals, the synchronicities, and say something yes that you might be afraid of. Say yes to something that you might be afraid of. Bill was a big part of cancer support community, as were many of those 120 participants in that book. And I saw how much they had gained from being in groups and talking to others about it. And groups were not something that I was particularly fond of. And what's so interesting to me is that when I would do orientations at cancer support community, so many people would say, "Well, I'm not a group person." I don't know that any of us feel like we're a group person. But once you join, as I did, I joined a group at cancer support community. And that was the way that I learned that there's no better way to heal than through a community. And very often we have to find a new community. It's not just talking to others like friends and family, but having amazing groups to talk to others who understand. The National Cancer Institute lists 5 huge advantages to joining a support group: feeling less isolated and judged, gaining a sense of empowerment and control, improving coping skills and a sense of adjustment, talking openly and honestly about feelings, and most importantly, reducing stress, depression, anxiety, and fatigue. What it doesn't list is the process of moving forward, which again, in some groups, some people do want to move forward. Some people do just want to go back to what they had before. When I was going through all of this, all of my cancer, my cousin's son was starting school at Pepperdine. He had moved from Ohio, where I'm from. And in high school, he had made over $1 million selling paintball equipment on the internet. He paid for all of his brother's colleges, and he paid for his own tuition. And one night we were having dinner, and he asked me what advice I would give a 20-year-old who was about to start his life. And I thought, here's a 20-year-old that has already done way more than most 20-year-olds. And he's asking me this question. I better have a damn good answer. But then I looked at him and instantly I knew it. And I said, if I could give anyone advice, it's to have the courage to take risks. And Ethan, you have that courage. You wouldn't have moved from Ohio to California to go to school, and you wouldn't have made all that money and given it away to your brothers if you didn't have courage. And the next morning, I sent him an email and I said, I'm so jealous that you have your whole life ahead of you. Okay, tears again, I'm sorry. He sent me back an email that changed my life. He said, and I quote, "It doesn't matter if you're 20 or 50, you still have your life ahead of you." This is the 20-year-old changing my life. And then he said, age can feel like the end, or age can feel like the beginning. And he made me realize I could be 20 again. I could just start all over. He had the exact same message as the butterflies. It doesn't matter if you have 70 years ahead of you or you have 2 weeks. What do you want to do? Right after he told me that, I called a friend in New York City who was a Broadway performer, and we started a new company called Next. Our purpose was to help people who were going through exactly what I was going through. They were struggling to find a new next for whatever reason, whether it was retirement or anything that they were going through in life. We wanted to help them try to discover what was next. A lot of it was based on what I had learned about cancer survival. It began with how to begin to heal. Step 1, allow the pain and sadness. You can only heal if you feel. Step 2 was to find hope. And step 3 was the exploration, just like joining a group. Everyone's next is normal. We can't compare what our next is going to be to others. For instance, some people love to work with children. Imagine the joy of helping a child with cancer if you've already been through it. Some people are artistic, musical, or performance. Just imagine how different art would be after cancer. One thing I decided to do was to switch my journal to art and my art to journaling. I looked up and I saw a painting that I had made that was hanging. This is a giant painting that I had hanging in my living room. And I just decided to start writing on it one day. 10 years later, I finished it. At the bottom line, there's 111 lines. And each line took about 30 minutes to write. But every day I would just journal on the art. And there it is, still hanging in my living room. And I can just look at my journal whenever I want. I very often just point to a line and try to remember what I was feeling that day. So some of the small beginnings is to start asking yourself questions. Again, these are all great questions to use in groups and in therapies. One of the things that we started doing, having people create what I called their autograph of life. This was mine. Dr. Bill Saltzman used to use this chart also with families at Cancer Support Community while he was doing his research on how cancer involves families. He had each family member do this, and then he would compare them. On the chart, you mark each year of your life at the bottom, and then where you were on a scale of 1 to 10 for happiness in that year. It's much like a corporation in their performance graph. It very often shows after an extremely sad period in our life, we bounce up to one of the best times in our life. The year that I went through chemo is very high in the happiness level, which you wouldn't expect. And yet the year after cancer was one of the lowest in my life. But then I bounced back up again. Again, thanks to the groups at Cancer Support Community. I learned that not only did I like the group, I wanted to be a facilitator of the group. We look back at our lives through this graph and we reflect on what we've learned. One of the songs that I love the most is Queen Latifah's "I Know Where I'm Going Because I Know Where I've Been." So much of where we can go in the future is related to what we learned in the past. And it's important, very important to remember that how we look back at our past. You can't change what happened. It's all about how you perceive it. And so very important is the only thing that we remember are the words we use. And that's why when I talk about cancer and I say it was the happiest year of my life, I completely forget about being in ICU so many times. And all of I don't remember that. It's only the words that I use. And a perfect example of that is Eve Ensler, who is the author of the Vagina Monologues. She once spoke at our Cancer Support Community luncheon. She told us that while she was going through chemotherapy, she decided in one of her early treatments that she would imagine the chemo drugs burning away all the traumas of her past. She chose to change her perspective from it being poison to a beautiful medication to eradicate her horrible past. She said that she soon started to look forward to her chemo treatments because they brought her amazing peace. Not only did the experience of cancer change her entire world, the medication that most people dread gave her a new meaning in life and a new outlook about her future. It was the words that she uses to remember it and how much that influences her. So again, going back to what we did with next is it's important, as I said, to ask questions. These are just a few of the questions that we created, and I'll go through them quickly. Start by asking small questions. What can I do tomorrow that might make me happier, improve my life? What is one small step that would bring me a feeling of accomplishment? What do my friends love about me? Man, these are all great group questions too. If I got out of bed 1 hour early tomorrow, what might I do that would make a difference? What did I love as a kid? That's huge. What if I called one person right now just to tell them that I love them? What would they say? Probably have you been drinking, but okay. It's also important to ask some of these questions. What does hope mean to me? These are much deeper questions. What might bring a new purpose to my life? What would make me feel more balanced in my life? And what would give me energy or motivation? It's interesting that some of our most difficult questions are the fun ones for our family or friends. So maybe pick a family member and ask, what do you think is the most important talent I have to share with the world? Who is someone you think could be a good mentor for me? What do you think holds me back? What kind of a future do you think would truly excite and motivate me? Where would you say I've made mistakes? And why do you love me? And then there's questions about your dreams. What is my greatest dream? What is keeping me from living the life that I dream? How would my life be different if I lived that dream? What is one small step that I might take towards a dream? And who might I ask the above questions? Who do I trust to be honest? If cancer teaches us anything, the number one thing that I want to convey is to enjoy life. All of these questions that I've told you are all working towards what might be and what could bring us happiness. And that's the goal, is happiness. So if I have any lesson, and in my book, this is the most important topic, it's to have fun. Sing, dance, laugh, play games, tell jokes, take risks, listen to Ethan, and know that your whole life is ahead of you. Enjoy it. Enjoy life. Thank you again so much to all of you for joining us today. There's some amazing speakers coming up. I hope you learn a lot. I hope you enjoy the process, and I hope you have fun. So thank you.
Bill, thank you so much for that incredible presentation. It's just an honor to be your colleague here at the Cancer Support Community, Los Angeles. Thank you.
Thank you, Julia.
Absolutely. And I'd like to take this opportunity to thank all of our incredible therapists, who we call facilitators here at Cancer Support Community Los Angeles, and our volunteers, and all of the doctors and professionals who deliver our program. And now it is my pleasure to welcome our next speaker, Dr. Jennifer Kelly. Dr. Jennifer Kelly is the director of the Atlanta Center for Behavioral Medicine in Atlanta, Georgia, and is the 2021 past president of the American Psychological Association. Board certified in clinical health psychology, her primary presidential initiative at APA was focused on psychology's role in achieving health equity. In 2018, Dr. Kelly served as co-chair of the newly formed Advocacy Coordinating Committee of the American Psychological Association Services. And for 23 years, she has served as the Federal Advocacy Coordinator of the association. A graduate of the 2003 class of Leadership Atlanta, Dr. Kelly has been recognized on numerous occasions for her advocacy on behalf of psychology, including recognition from the APA Services Practice Leadership Conference and a legislative award from the Georgia Psychological Association. We're so happy to have you here with us today, Dr. Kelly. Welcome.
Thank you so much for allowing me to be here to discuss my presidential initiative. I will start the screen share. And I will say good morning and good afternoon, depending on where you are in this world. I would like to spend some time with you talking about and discussing my presidential initiative, which was last year. I was a 2021 president. And I would like to also put in some information about what it is that we can do to make a difference as it relates to achieving health equity. So these are some of the objectives that I have here for today. And I really want you to have some understanding about how the current healthcare practices contribute to health inequities. And identify and understand how environmental and social factors systematically contribute to health inequities. And so I want to move and get specific about some health disparities and the incidence of cancer and treatment outcomes, and look at finally be able to understand, articulate at least some ways in which psychological science and practice can help address the health inequities. So when you think about health, it's really more than just about healthcare. There are so many factors that are associated with health, whether or not it's patient protection, insurance coverage, your interactions that you have with the provider. You're talking about financing. So we're talking about more than just healthcare. When we talk about health disparities, the CDC defines it as preventable differences in the burden of disease, injury, violence, or the opportunities to achieve optimal health that's experienced by individuals who are socially disadvantaged. And I did want to highlight those two things. It's preventable and it's by socially disadvantaged populations. Again, I highlighted the social disadvantages, and the WHO says that when you look at health disparities, they are significantly associated with social disadvantages. But the WHO says they're systematic and they are avoidable. And we know that they are facilitated and exacerbated by the circumstances in which people live and work, and they are intensified or influenced by political, economic, and social factors. So when you start thinking about health disparities, what you're thinking about is that you have certain groups who have systematically experienced greater obstacles to health. And they are based on many of these factors here. And what I did was I did highlight mental health because that is what it is that I do. But all of these factors impact on one's ability to achieve optimal health. When you think about health disparities or health inequities, you have to think about the social determinants of health. And they are the conditions in which people are born, grow, live, work, and age. And we know that they are influenced by these socioeconomic, these factors such as socioeconomic status, how much money you earn, the income that you have, the level of education that you have. How far did you go in school? Did you have vocational training, higher education? Your level of literacy. The neighborhood in which you reside, whether or not you have sidewalks within your neighborhood, the zip code in which you reside, the community in which you live, the kind of support that you can have in your community, and whether or not there's increased exposure to violence or trauma within your community. And of course, the healthcare system, your health coverage, your ability to interact with the provider. And what we know is that what goes throughout those factors are racism and discrimination. So you cannot think about the social determinants of health unless you look at it within that context. And from that, we get the health outcomes. So I want to spend a little time with you, giving you information about the evidence related to health disparities. So I want you to compare this to the non-Hispanic whites, and that's the number roughly 6% down at the bottom, as it relates to health insurance and coverage. So the number uninsured, you have 16% of Latinx, roughly 15% of American Indians and Alaska Natives, probably 10.5 or 10.6% of African Americans that are uninsured. As it relates to the chronic health conditions, you have people who are reporting fair or poor health. You have 17.4% of American Indians and Alaska Natives reporting fair or poor health. And 14% of African Americans, 10% of Latinx, and you want to compare that to roughly 8% of the non-Hispanic whites. As it relates to chronic health conditions, you have 42% of African American adults suffer from high blood pressure compared with roughly 29% of white adults. 80% of African American women are overweight or obese compared to about 65% of white women. And you have 21.5% of Hispanic adults having diabetes compared to 13% of white adults. And here's another statistic. Asian Americans are 40% more likely to be diagnosed with diabetes than white Americans, and they are also 80% more likely to be diagnosed with end-stage renal disease. In terms of the leading causes of death, what we know is that there are 11 infant deaths per 1,000 live births among Black Americans. And this is something that's getting more attention, not just in the media, but more legislative focus, because this is almost twice the national average of 5.8 infant deaths per 1,000 live births. As I started really looking at the research, it became really startling to me to see the health disparities in the Indigenous American. And I wanted to spend just a little time talking about that. So one of the things that we know is that they have experienced just in lower health status when you compare them to other Americans. And it's related to inadequate education, disproportionate poverty, discrimination, and delivery of health services. And the American Indians and Alaska Natives that are born today have a life expectancy that's 5.5 years less than the US all races population. You're talking about 73 years to about 78 and a half years respectively. And the American Indians and Alaska Natives continue to die at much higher rates than other Americans in many categories. And these include such things as chronic liver disease, including cirrhosis of the liver, diabetes, unintentional injuries, assault, homicide, suicide, and chronic lower respiratory diseases. And the suicide rate is 3 to 6 times higher among American Indian and Alaska Natives than among their non-native peers. And this is one of the main concerns that they have. And they're really trying to understand this, but one of the things that they think can account for this is the lack of adequate funding of the Indian healthcare delivery system. So I wanted to spend a little bit of time talking about race, place, and health. Where you live really does matter. So this is a little bit busy, but I want you to just look at the light blue columns and the dark blue columns, and I'll tell you what it shows basically, is that the Black children in counties with high segregation, and that's indicated by the light blue columns, they experience worse poverty, higher infant mortality, which we just mentioned, and lower high school graduation rates than those in the less segregated counties, which are represented by the dark blue columns. So where you live really does matter. So the link between race, place, and health, it has really been in large part just related to that history of unequal access to opportunity in the United States. And it's based on the history of policies and practices that just really systematically denied these things to people of color. So addressing these health inequities that's caused by the residential segregation will really require initiatives that are localized, multi-sectorial, as well as equity focused. So I wanted to spend time talking not just about what we see in the United States, but there are disparities globally. And so, for example, for age, what we know is that 94 people over the age of 60 may have made up 94% of the COVID deaths in the European Union. Just staring at us is that we see 2/3 of the children under the age of 5 who suffer from stunted growth are from Africa and Southeast Asia. And you can also see it as relates to race and ethnicity, gender and sexual identity, as well as socioeconomic status. So if you look at things from a global standpoint, it seems like there are positive trends that are going on in terms of looking at health status and more health equity. However, if you do more detailed observations, what you see is that there's a persistence of health problems and diseases that really should have been eradicated by now, or they should at least have been more controlled. And one of the things that we're also seeing is that we're seeing more inequities, sometimes across nations, but also within nations, and among the social or racial ethnic groups, which is one of the things that we see in the United States. And according to the WHO, the income level of a country has a direct correlation with life expectancy. And the life expectancy of low-income countries, 18 years lower than the high-income countries. The other thing that we know is that there's an estimated 800 million people worldwide who are chronically hungry. And it's ridiculous for this to exist because what we have is enough food production to cover over 120% of the global dietary needs. So we have a lot of work to do. As it relates to mental health, The number of suicide attempts by adolescent Latinx females was 40% higher than that of white females. And there's been a lot of research to really try to understand what that's all about. And suicide was the leading cause of death for Asian Americans ages 15 to 24, and the second leading cause of death among American Indian and Alaska Natives between 10 and 24. One of the things that we knew is that, yes, health disparities existed. We knew about health inequities, but when COVID hit, it really heightened our awareness of that, and we really got to see health disparities really just staring us in the face. And what we have found was that the Black, Indigenous, and people with lower incomes, older adults, and people with disabilities, if you think about all of those factors, they have the largest impact from COVID-19 in terms of infection rate and mortality. And globally, one of the things that we've seen is that it really halted the critical mental health services that really have been needed. That's in 93% of the countries. And we know that the demand of it has been increasing. Now, this is what the latest that I could find was in September of 2021. So it's about a year ago. And this is what we were seeing as it related to the cases, hospitalizations, and deaths from COVID-19 infection. So this is compared to the white non-Hispanic persons. And I'm just going to go to the one with deaths. So the American Indian or Alaska Natives were 2.4% likely to die, more likely to die from COVID. And Black Americans and non-Hispanic persons, 2%. And the Latinx or Latino persons, 2.3%. So why was there such a deadly toll of COVID-19 on the Indigenous population? So we know that historically, the population has experienced a higher degree of socioeconomic marginalization. They have a disproportionate risk for public health emergencies. And they do not have the same access to effective monitoring and early warning systems, and they also lack adequate health and health services. The other thing that we know is that they have high representation in the service populations. And these are things that I found that were more startling. So the older age, multi-generational housing, lack of running water, communal wells, all of these things just increase the impact of COVID-19. And I did not know this, that 40% of the Navajo households did not have access to running water, and 30% do not even have electricity. So the marginalization, segregation, and discrimination of these tribes really impacted on their ability to manage within the COVID-19 situation, which, by the way, I think that we're still in. And we also know that it's had higher death tolls on the Black Americans and the Latinx. And one of the things that we know is that bias plays a role in it, with either explicit bias or unconscious bias. And it's, for example, determine if a patient will receive proper testing and treatment in the early stages of COVID. And the Black Americans have a much higher prevalence of the health conditions that increase the risk of death from COVID-19, such as diabetes, high blood pressure, and heart disease. And the African Americans, the Black Americans, and Latinx are less likely to be able to work from home. And they're forced to take public transportation, increasing their risk of exposure to COVID. And many of the minority and low-income communities are likely to experience food insecurity. So you're going to have higher rates of obesity and diabetes, and that's also one to make them more vulnerable to COVID-19 and the effects from that. And we know that decades of segregation, discriminatory housing policies, as well as poor environmental protections have left many African Americans and Latinos living in substandard and high density housing. where there's higher air pollution, leading to higher rates of asthma and other diseases. And the other thing that we know is that the minorities are more likely to live in the healthcare deserts, in which they do not have the same level of access to the primary care physicians or even the emergency rooms. And one of the things that's happening here in Atlanta is that one of the, we have 2 hospitals in Atlanta that have a level 1 trauma center, and one of them's closing. And that's partly because the governor just did not approve to have Medicaid expansion. So, and it's an inner city hospital. So that it will take a longer distance to get to care that they need. So one of the things that we know is that health is not a direct result of behaviors and actions. And yes, we do know that individual actions and behaviors can play a role in health, but more importantly, the environments in which they exist and the policies that are put in place that shape people's opportunities determine what choices they have to make. And one of the things that we also saw during COVID-19 was impact of mental health. How did it impact the mental health? And you can see the symptoms of anxiety and depression during the COVID-19 pandemic by race and ethnicity. And you see the non-Hispanic Blacks and Hispanic Latinx have the higher rates. You want to compare that to all adults. The other thing that we have been finding is, since we've had an expansion of telehealth services, and we thought that it would be have increased access to mental health care, but we have to be aware of how this can impact on people of color or more marginalized individuals. So, for example, you have to have access to high-speed internet or broadband in order to have the equitable services. And you have people who just do not really know how to use the technology. They may have difficulty hearing, can't use a telephone, or they may not even have enough minutes on their telephone to allow them to have access to these services. So we have to be aware of that. So one of the things to think about as relates to racial and ethnic disparities, not just from the moral and ethical reasons why you want to improve that, is that it costs. And so a 2011 study showed that the economic cost of health disparities due to race for African Americans, Asian Americans, and Latinos from 2003 to 2006 was over $229 billion. And the Urban Institute calculated that the Medicare program, just the Medicare program itself, would save close to $16 billion per year if healthcare disparities were eliminated. And that's significant. So I want to spend just a couple of minutes talking about health disparities by race and ethnicity as it relates to cancer health disparities. Studies have consistently shown that African Americans have the highest mortality rate from all cancers combined compared with any other racial or ethnic group. As it relates to multiple myeloma, the incidence and mortality rates are twice as high in the Black population as in the white population. And transgender men are more than twice as likely to get cancer than cisgender men. And for people living in rural communities, the combined death rate for all cancers is 17% higher than it is for people in the rural areas. And if you look at this, this chart, this graph really shows it. So if you look at the death rate, and you can see as it relates to the Blacks, you can see that they, and male and female, they have the highest incidence of deaths from cancer, highest rates of cancer deaths compared to any other group here. Now, as I started doing the research about this to provide some slides, I came across this study that just recently came out. And it was in August of this year, and it was published in Advances in Radiation Oncology. And so researchers from Huntsman Cancer Institute at the University of Utah found significant healthcare delays for people of color when they tried to obtain this more advanced targeted form of radiation therapy called intensity modulated radiotherapy, radiotherapies is IMRT. And what that intervention does is it matches the precise contours of the tumor to minimize dose. So it will allow for decreased side effects and improves quality of life. So you're not going to have as other tissues as involved. It's more expensive, and many insurance companies require prior authorizations, which sometimes would allow, which would result in delays in treatment. But this is what they found as they were looking at this. They were not looking for this, but they found these results. They found that Hispanic, Black, Hispanic, and Asian patients were significantly more likely to have delays in the initiation of treatment with this procedure compared to non-Hispanic white patients. And it was across nearly all included disease sites. The other thing that they found out was that although private insurance was associated with more timely treatment in white, Hispanic, and Asian patients, the Black patients with private insurance had longer delays than those with Medicare. And they were not looking at that, but that's what they found. As it relates to mental health condition, it's estimated that up to 1/3 of the people treated for cancer in hospitals have a common mental health condition, and the rates of major depressive disorder are thought to be up to 3 times higher with cancer patients than in the general population. And there's a range that approximately 8 to 24% of people with cancer are also living with depression. And it also shows that youth and young adults are a greater risk of depression and other conditions compared to other adults with cancer. And studies have shown that those who are dealing with mental illness, dementia, and substance abuse are more likely to have lower chances of survival after the cancer diagnosis. And one study found that those who received the treatment and had fewer symptoms of depression had longer average survival times than those who had more symptoms. So we know that it's important to treat the mental health symptoms. And they also showed that they have better medical care and a better quality of life. And that was a meta-analysis that identified about 3,700 studies. And about 70% of these, of the people that they looked at were female. And they range all from between 18 and 79 years of age, and all the continents were included with the exception of Africa. And what it showed was that people with mental illness are less likely to undergo screening for cancer than the general population. And they found that this to be particularly true of women and for people with schizophrenia. And they said, while people with mental illness were less likely to receive the screening than the general population in any part of the world, they found the greatest difference in Asia, and the least difference was found in Australia. And so they found out that the cancer screening programs that work with the general population really do not appear to work as effectively with people with mental illness. And we need to start doing something very different to have the reach for the patients with the mental illness. And they found disparities in the rural population as well. So the rural cancer survivors reported greater symptoms of anxiety and depression, greater distress, and more emotional difficulties than in the non-rural cancer survivors. And we also know that the people in the rural areas do not have as good of access to healthcare. And you start thinking about that when you start looking at the expansion of telehealth services as well. So we really need to start looking at that. As it relates to the veteran system, the VA system, and one of the things that they found is that veterans with mental health conditions were more likely to die of lung cancer or from any other cancer than those without the mental health conditions. And they found that if they did receive the treatment, they have better success, better prognosis. And so in one study, they saw that of more than 50,000 veterans that were treated with lung cancer within the VA system, and they received the treatment, including substance abuse treatment, they lived much longer than those who did not receive the treatment. And so they also found that the support was much more, was quite important for them to have. So mental health treatment and the support will be important for that population. So here's a study from the American Association for Cancer Research. This was the progress report of 2022. And so it identified the priorities that policymakers need to undertake in terms of addressing the disparities in cancer. Increase funding for research and public health initiatives that's aimed at addressing the disparities. Improve the collection of data. Increase the diversity in the clinical trials, and support cancer prevention and screening programs to have better outreach and access to more affordable and equitable mental health care, and to recruit a more diverse workforce in science and other medicine-related fields. And the interesting thing is that these are the same recommendations that my task force came up with, as we will see. So one of the things that Martin Luther King said was that of all the forms of discrimination and inequalities, the injustice in health is the most shocking and inhuman. So I want to move away from the health disparities to move towards health equity. And what we know is that what we want to do is to have the attainment of the highest health of all people, and to value everyone equally. And it will focus on ongoing societal efforts to address avoidable inequalities or inequities, the historical and contemporary injustices, and the elimination of health and healthcare disparities. Equality is not the same as equity. So, because if you look at on the left side, you can see equality, where they all have access to that same box, right? But not all can reach the fruit. But if you look at equity, what you're looking at is giving the people what they need, when they need it, and the amount that they need it, so that they all can have access to that fruit. So what it would mean is that everyone will have a fair and just opportunity to achieve optimal health. And it means reducing and ultimately eliminating disparities in health, as well as those determinants. And you have to address mental health if you're talking about health disparities. And we also need to focus on the social determinants of health. And I put this slide in because I think that it's important. So what it does is it looks at the medical model on the right side and the socio-ecological model on the left side. This is developed by the Bay Area Regional Health Inequalities Institute. So what it's showing on the medical model is saying that our health is influenced by a combination of our access to healthcare, genetics, and personal choices. But guess what? This model is only responsible for about 30% of our health outcomes. The other 70%, the socio-ecological model, lies within our social, political, and economic environments. So what we know is that the systems and the rules and practices they enact and promote determine the distribution of resources and who has access to them. So if we're going to address health equity, we really have to look at how structural racism really plays a role in this, and discrimination. So in order to make a difference, we have to focus on dismantling racism in our science and pedagogy. So given all of that, this was my initiative, was looking at what psychology's role would be in achieving health equity. And so what we know is that their environmental, social, and behavioral factors contribute to health disparities in interacting ways. But we also know that these are all within psychology's expertise. And so it is up to us to really try to find, number one, and find the concrete ways to make improvements in the populations, but also how do we go about enacting those and making that difference? So I put together a task force on psychology and health equity. And I was really wanting to get people with a broad level of expertise in all the different areas and the ones that could really make a difference in what it is we were trying to do. So if these are the people that we ended up having as part of our task force. And I must say that it was quite a broad group of people, and from independent practice to researchers and in medical school environments. And even the co-chair has been with the WHO, Dr. Jeffrey Reed. So one of the things we wanted to do was really articulate a vision for the role of psychology in advancing health equity. And we wanted to develop recommendations to promote really the innovative approaches for psychological science, education and training, practice, and public policy and advocacy. And we wanted to give these recommendations to the various organizational units of APA. And we also wanted to have a policy, and not just one that will be put on the shelf, but some things that APA can really enact as it results in, that can result in making a difference in terms of psychology's role in achieving health equity. So these are some of the products that we had. We had the summit meeting, and there's a special issue of American Psychologist that focuses 100% on health equity. We had a presidential programming at the convention last year, and the recommendations for the policy. And we wanted to have all voices included and look at all of psychology, and not in silos, but what we can bring to the table. And so we had that roundtable meeting that really received information from our stakeholders within psychology that could help us in terms of articulating that the vision of what psychology's role could be, and give us some concrete recommendations of what we can do. So one of the things that we knew is that it was becoming real clear that, yes, psychology can make a difference, but we also knew that we had to do some things within our own house if we wanted to make a difference. Because remember, I talked about racism and discrimination just is threaded throughout health and health disparities and within the social determinants of health. And so we had 3 major resolutions that were passed at our last the council meeting in October of 2021. And one was the apology to the people of color for the role of APA in promoting, perpetuating, and failing to challenge racism, racial discrimination, and human hierarchy in the United States. And the second resolution was the role of APA and psychology in dismantling systemic racism against people of color in the United States. And our third resolution was advancing health equity in psychology. Now, and these are the links to all of those resolutions. And one of the things that you can do is just go to the apa.org and just type in apology to people of color, and you will be able to get all of those resolutions. And please spend some time looking at those, because they were very thoughtful. And I'll give you some highlights of the health equity resolutions, but the main, this is resolution number 1. And so this is the main focus of that apology. So we had a historical chronology that was conducted by the Commons Center on the history of psychology. And we had a series of listening sessions to capture the oral history as well as just to the written history. And we also had a public survey that we spearheaded. And it's really a broad-based apology to people of color. And just presented a series of action steps in which we can do to make a difference. And this second resolution was really to look at our role in helping to expose, understand, and ultimately dismantle racism across all these different levels. So the first thing is to apologize for what it is that we've done. Now, okay, we've apologized, and now we can really make some changes, and these are some things that we can do. And then the third resolution as part of that package is in health equity and psychology. And so in education and training, one of the things that we did is that we made these recommendations. Support comprehensive evaluation of early psychology exposure, recruitment, admission, and retention processes. And we wanted to really reach out to recruitment programs and really target undergraduate programs, tribal colleges, and high school. We wanted to have a diverse profession. And we want to have also health equity included in psychology curricula. And we know that not every training model, not that box training model will work for everyone. So we want to encourage more traditional, more flexible training models for graduate education, and also have mentoring programs to really, not just mentoring of the students, but mentoring of the faculty as well. And we wanted to support training programs throughout the training sequence, including support funding for curriculum development. And we really wanted to have health equity infused into the programs. We wanted to advocate federal research funding agencies such as NIH, NSF, and HRSA, and private foundations for dedicated, sustained, and increased funding for research on health equity. And we also wanted the research to include scholars of color, the ones that really have that knowledge about health equity issues. And we also wanted there to be more collaborative efforts with the historically Black colleges and universities and the tribal colleges. And we wanted to have promote really having more authors and scholars of color involved as journal editors. And we wanted to minimize the bias, because we understand what some of the challenges are, and we have to make a difference and dismantle some of these the difficulties that we have. As it relates to professional practice, we really wanted to support innovations that deliver competent as well as financially viable assessment and treatment, as well as prevention for diverse populations and communities, and have more CE programs for practitioners. And we wanted to advocate for health insurance service reimbursement that will cover more diverse models. And we wanted to have advocacy really throughout the entire process. And we wanted the development of the training models and support the training programs to help students really enhance their advocacy skills, as well as partner with other coalitions and other professional and policy-making organizations to address health equity issues in communities of color. So we had this great package about health equity, and we had the resolutions, all three of those resolutions. And so we wanted to not just sit up on a shelf. So one of the things that we did is, as part of this resolution, we said, these are the things that we want. Well, we've already had the audit of the APA activities on health equity, and that was in February of this year. We had that, and it was a pass, and we saw all the things that were done. We wanted to have a 5-year implementation plan. And so one of the things that we wanted to do is to have the CEO come back to us, the executive leadership team, and say, this is what we're doing. We have 5 years for doing this. The other thing that I think that's important to note that we have is that we just approved in August of this year the racial equity plan, and APA has committed $1.1 million to the plan. But we know that in order for this to be successful, it's going to have to be more than just us. We have to have people of color to be part of that. So I'm going to finish by the recommendations for a more equitable mental health system. And one of the things that we need to do is to work more upstream. And so if you're working more upstream, what you're going to see is that everyone in all communities should be able to have safe neighborhoods, fair standards of living. We can dismantle racism and have a more healthy environment. So we want action on that societal level. As we do that, we will have less downstream, less homelessness, less poor health status, less obesity, less incarceration. We want to address the social determinants of health. Embed the services in the places where people go. And we want to empower people to be healthy, to have that screening. And work with people who are healthy in addition to working with people who do have the mental health challenges. And we want to broaden the set of interventions that we use. Let's go out into the community and focus on health at the community level. And we want to really work on improving mental health literacy. And we want to reframe how people view mental health. That is something that is inside of all of us. And so as part of my presidential initiative, one of the things that I did was I wrote an article. And here's you can take a shot of this, and please go to this. And it's Building a More Equitable Society, Psychology's Role in Achieving Health Equity. And it's in the American Psychologist, and it just came out. So thank you. And I am now available for questions. I am only 2 minutes over. No, I'm only 1 minute over for questions. So thank you.
Thank you, Dr. Kelly. You're right on time, 1 minute or 2 minutes. That was a wonderful, wonderful talk. There is a question here that's come in about unconscious bias. So you touched a little bit on conscious and unconscious bias. And what strategies would you recommend to deal with unconscious bias? And are there any tests that psychologists use to determine unconscious bias?
Well, that's a good question. And I don't know if and I'm sure because they have tests for everything now, but I'm sure that we could find a test for that. You know, they talk unconscious biases. There are things that other terms for that. It could be hidden racism, or we can call it microaggressions. But I think that one of the things as it relates to unconscious bias is that if we see it, then I think it's our responsibility to bring that up to our colleagues and say, hey, I think that there is something going on here. So we may not be aware of it, but there are other people that we're working with, our colleagues are aware of it. And so we have to have the courage to just let people know what's going on here. And as I was stating, that it's not up to the people of color to do this. I mean, we can only do so much, and we're going to need our colleagues to help us through this process. Mm-hmm. And it's like, well, you don't really, I guess you could do a test for it, but there are many diversity kind of training programs out there that can really focus on this. But I bet if you can Google it, we can find that there are tests that will look at unconscious bias.
Right, I'm sure. Thank you. Yes, it's we're all in this together. So
right.
That up, and like you said, having the courage. Let's see. There's another question that has come in. What are practical steps an individual mental health professional can take to have an impact on health disparities?
Oh gosh, yes. And so one of the things, I'll tell you about my practice. I'm a mental health professional. I'm an independent practice. Uh-huh. So one of the things that I've done, but some people say that I'm different in this regards, because I've been out for a very long period of time. And most of my colleagues don't even take insurance anymore because they've had such a, they've been out for so long, they have a standard of living that they want to aspire to. But one of the things that we can do, I would say, is to put time on our schedule, number one, to work with people who don't typically have access to that care. I'm a Medicare provider, because I believe that everyone should have access to adequate mental health care. And I am on insurance programs. I very rarely see, it's very, very rare that I see patients on cash basis, because the population that I work with as a health psychologist, many of them do not have that kind of money. So I would say to you, number one is be able to open up your practice to people who don't necessarily have access to the kind of services that would be higher pay services. The second thing is look and think about what you can do in terms of improving your knowledge in working with these diverse populations and your competency in working with diverse populations. And most state psychological associations now, if you go to their annual meetings, they are having more of their programs that are focused on working with people of diverse populations. So it's like, look at some of those and really try to increase your own competence and confidence in working in with these populations.
Thank you. And a comment. Well, where did that comment go? Somebody, you were right. There's a test for everything, Dr. Kelly. Oh, here we go. A participant here recommended the Harvard IAT as a test for implicit bias. So
there you go.
There you go. Test for everything. There's something that I want to ask you just from the heart. I am not a therapist. I'm not a clinician. I'm just a person working here in Los Angeles in this cancer care landscape, trying to ensure that all people have access to the care they deserve. And your presentation was so moving to me because the statistics, they're not only sobering, but they're heartbreaking. And I have to say that I had a sense of overwhelm. You know, and I'm just wondering if you have any advice for those of us working in this field and how to strategies to deal with that sense of overwhelm.
Right. Thank you for saying that. And I think that one of the things that happened is that when I started looking at all those statistics, if you focus on those statistics, it can be just so overwhelming. And it's like, so first of all, the question is, well, racism doesn't exist and, health disparities don't exist. And then I present the science and I present the data. And it's just like, people would just like sit back in their chairs, like it is what it is. So one of the things that I said we need to focus on now is the move away from that, because it can be so overwhelming, and look at and think about what it is that we can do to make a difference, because the statistics are out there.
Yeah.
And the data's out there. And so what it is that you can do, how do you open up your practices, whether it relates to working with people with lower socioeconomic status, working with disadvantaged populations, what it is that you can do to increase your confidence and competence in working with this population. So I've been trying to move away from health disparities, knowing that it exists because it's part of the work that I do as a clinical health psychologist, and moving to like, okay, my focus is how to help this person navigate the healthcare system, how to help them go about having that access to care that they desperately need. And I have found myself really, if I allow myself to start focusing on, it's like, I'm going to help this patient navigate this healthcare system. And many of them just do not know how to do that. They don't have that health literacy. And so think about what it is that you can do to try to help make a difference. I had no idea that I would have such a groundswell with my colleagues with APA when I took this on as my initiative. What I did know was that when I was thinking about it, was like one of the things that characterized my practice was I saw a lot of health disparities. And I knew that if I was having this challenge, then other people will be having these same challenges. And then 1 month later, when I said that I was going to have this as my initiative, then COVID hit. And then we started seeing health disparities right there staring us in the face. So the other thing that I'm going to say to you too is that if you're working with this population, always make sure that you're taking care of yourself as well, because it can really be draining. So make sure that you're doing the things that you need to do for self-care.
Thank you. Good advice. Well, I think that we're at time, and as you said, psychology can make a difference. And I want to thank you so much for your presentation and for enlightening us and educating us. We really appreciate it, Dr. Kelly. And I hope everybody will check out that article that you mentioned at the end of your presentation.
I appreciate it. Thank you.
Absolutely. Absolutely. Take care.
Thank you.
Introduce our next speaker. Dr. Shannon Cava is a clinical psychologist specializing in psychosocial oncology and is the Chief Clinical Officer and Director of Programs and Research at Cancer Support Community Los Angeles. Her research interests focus on multidisciplinary engagement to address health inequities and support the psychosocial needs of pediatric, young adult, and adult patients and caregivers. She is the current chair of the Health Equity Committee of the American Psychological Association, an active member of the American Psychosocial Oncology Society. Dr. Cava has engaged as a community advisor and co-investigator in research collaborations with American Institute for Cancer Research, Kaiser Foundation Research Institute, Providence St. John's Health Center, Cedars-Sinai Medical Center, and UCLA Center for Cancer Prevention and Control Research. Please welcome Dr. Cava.
Thank you, Myra. It's so good to see you. Thank you for hosting our event this year. And it's wonderful now getting to see all of those that are participating and watching. So hello to all of you. Thank you for joining. Today, I'm going to be talking about thinking outside of the box. And this is really about utilizing multiple systems of partnerships in a way to create models of cancer care. And I am just very honored to be coming after the conversation that Dr. Jennifer Kelly started, which really kind of laid the groundwork. And I think sometimes the what can we do might be how can we collaborate and how can we work together to do more. I have no financial disclosures. So I'm going to start with telling you a little bit about me, and this might be a little unusual, but bear with me, and there'll be some reason to this as we get on to the top. So this is me when I was young. This was the first day of kindergarten. I had this idea that I was going to take the bus. I was an only child, and I felt very independent. I think that somewhat sticks with me now, but I was really excited to take the bus. Only realizing later the impact that that may have had on my mother and my family, because this was one of many series of the bus driving away. But that was part of my kind of early life. Moving on to my awkward years, this was me, I think it must be 7th grade. I was on a Zoom call much like this actually, and I saw all these text messages coming through and I couldn't figure out what was going on. And I realized that my husband had found this photo and shared it with all of our family on a text chain. And this has been now named my Spicoli years, if you have watched any Fast Times at Ridgemont High. And oh, some awkward years continued. This was me with sporting my broken arm just a couple weeks ago. So that might be puzzling why I showed you those photos, but we're going to put those together as we get into the presentation. Some of the learning objectives today are to design and utilize a positionality statement, to conduct research or health equity assessment to support your own research and support your own practice, to list values of partnering with multidisciplinary teams and other community-based organizations, as well as utilize existing models of collaboration to create effective partnerships. So we'll take a look at some community partnerships. What we're going to be talking about today in terms of partnership or some opportunities to collaborate are looking to work within disciplines, across departments, even across institutions. And we'll highlight a lot of community-based. Being here as the Chief Clinical Officer at the Cancer Support Community Los Angeles, we are part of that community-based arm, and I'm excited to talk more about that. I also had the great honor to participate in the Health Summit last year, and I think today's a good day to kind of start where I left off the last time, which was with this and how we can create an evolution of community partnership, utilizing a lens of health equity to collaboratively engage communities, revolutionize supportive care for families facing cancer. And to do all of this with inclusive targeted support to enhance the value across the healthcare system. Looking first at community-based participatory research, this gives us a great way to understand how research can be conducted within the community, but not just within the community, at the community's need and with the community's involvement. Community-based participatory research is a partnership approach, which it involves the researchers and the community stakeholders to engage together as equal partners across all aspects of the research process. Looking at an illustration, this helps me to really identify the core components. So these are what CVPR is really made of. And I know this is really small, but it's looking at accessing community strengths and dynamics all the way to designing and conducting interventions or policy, to disseminating those research findings and translating those research findings into programs. But the piece I really want to highlight today is in the center, and that's maintaining, sustaining, and evaluating the CVPR partnership. So with community-based participatory research, the partnership is in fact part of the research and part of the goal. And they've broken it down to different elements of the group dynamic, including group membership, equitable participation and communication, establishing norms for working together, developing trust. And remember that one, we're going to have that threaded through our talk today. In addition, selecting and prioritizing goals and objectives, identifying community strengths and concerns, looking at leadership, power, influence, addressing conflict, and establishing steps if conflict were to come up, what would you do to address it? Strategies for working across diversity, and partnership assessment. So this isn't a one and done. We are going through this at the beginning, and you're continuously evaluating the way that you work together in order to have this research be successful. So taking that and looking at how partnership may apply to our work relationships and our academic relationships and our mentors and esteemed leaders, I'm going to look at it that way. So think of a mentor. This is just a little activity that we can do. Think of somebody that you look up to or that assisted you early in your career. And even if you're at the top of your game right now, really think back to those that really helped you lay the groundwork for where you are today, those that you felt you wanted to emulate. So as you think about this, what qualities come to mind? How did you feel when you were working with this person? Think about the characteristics of this person that resonated with you. And maybe you have already started to utilize those in your own work. Maybe there's some as you consider now that you'd like to recall fondly and think, how can I incorporate that into my work? What attributes do you hope to emulate? And how can these characteristics support your collaborative goals? Are you thinking of characteristics of somebody being a good listener, a sounding board, being flexible, valuing diversity of perspectives, being non-judgmental, being knowledgeable? Are they able to give constructive feedback? Were they honest and candid? Are they able to network and find resources and act as a model? So thinking about that, thinking about how you consider a mentor of your own and how you want to be a mentor and leader, I'd like to look closely at some data that came out of an article of Park et al. This came out in 2020, and the article was Co-Creating a Thriving Human-Centered Health System in the Post-COVID-19 Era. So this is really coming out of how did leadership respond? How did leadership pivot and learn from the COVID pandemic? Really looking at and focusing on workforce well-being and burnout prevention and how that's influenced by the organizational and leadership practices. What do we have in our control to alleviate some of that? Post-crisis leadership actions often define organizational culture for decades, and it can lead to long-term stress, or how we respond in trauma or to the COVID pandemic can also lead to post-traumatic growth. unprecedented opportunity was seen to prioritize organizational structure. And strategies that they identified that were successful for organizations and businesses was to attend to the structural and technical breakthroughs. I know we were not on Zoom for our conferences in the past, right? So there's something with technology that we can lean in towards. Focus on the relationship and cultural leadership strategy. What does the culture look like? And what culture are you creating when you have a collaboration? Because you're doing that now with a partner. And maintain presence and creativity to connect a team. So having that lead to maybe entering into a partnership, I like the idea of a closed mouth is never fed. And I heard this kind of early into my return to academia and going back to school. And it gave me the strength to be able to reach out and ask for help, reach out to ask for mentorship. And I continue using this because this is how I think we can work together. We can collaborate. We can get out of our comfort zone because we can have the ability to ask. So coming out of the American Medical Colleges, and this is a nonprofit that identifies itself as the National Center at the intersection of community development and health. They're looking at the value of partnership designed with sharing expertise and resources and responsibilities with communities for achieving shared goals. So with is really important here. And that's done so through trust, respect, humility, and for mutual benefit for both parties. This includes community-based learning, engaged research, and healthcare delivery, all to ensure the health of all. And this goes back to, hopefully you were able to attend Dr. Kelly's talk of not just the social determinants of health, but the definition of health equity to really make sure that everyone has access to being healthy. The goal of the medical schools and teaching hospitals that are affiliated with the American Medical Colleges is to work to ensure that the health of all is ensured by collaborating with communities across clinical, research, and educational missions. So with this, I just started kind of Googling for fun, and I thought, okay, well, let's use the idea of with. But if you do a very simple Google search, you find out with is defined by the example of a nice steak with a bottle of red wine. So they went right to drinking. I thought that was interesting, so I took a little deeper dive. This is Merriam-Webster's definition, and this really talks about being a participant in an action. And I think that's a great way to lead us into conducting a health equity assessment. This is an actionable step that I'm excited to share with each of you, and it gives us a tool that we can use. So the health equity assessment tip sheet, and this can be put into the chat, so you will all be able to access this without having to copy down the URL code there. But this is also coming out of the American Psychological Association and the Health Equity Committee. So last year, they were tasked with Equity Flattens the Curve, and being able to address that idea of equity, putting together this. So this is for all mental health providers, as well as all individuals in healthcare in general. And this is setting the stage for equitable partnership. In terms of those actionable items, it's looking deeper into our own personal and institutional practices and potential biases. And the tool is to self-assess health equity in the practice and research comes out of the Health Equity Committee. So looking inward, trying to reduce inequity and bias within your own practice, uncovering those policies and procedures and potentially decisions, what is existing that can be changed to make a more equitable provision of care. And there's some quick tips. The conditions of the environment where people are born, live, learn, work, play, worship, and age. This is the social determinants of health. Dr. Kelly went into a little bit more detail in explaining them, but all of these come into play. So being aware of the social determinants of health of those that we're trying to reach and provide services to, and to also to adjust and modify how we provide services, I think is a very unique way to look at this and what the control that we have in being more equitable. So again, looking at the sources here, looking at health equity and the person's overall health and quality of life and how they're influenced by social determinants of health. And some data here that really kind of shows that the outcomes in terms of economic loss, lower rates of education, higher rates of healthcare expenditure, unemployment, that these are possible inequities that we need to be aware of as we design our practices. This also shares some questions that you can utilize to uncover some of your own practices and internal structures that could be reshaped, redesigned. So questions in terms of equity, diversity, and inclusion in your staffing, educating on health equity issues, community and professional partnerships, which is a lot of what we'll talk about today. Even location and proximity to public transportation and the hours that you're giving services out to your clients and to your patients. How can that be changed? So in terms of quick tips, these are just 5 to really start looking at your organizational's role in achieving health equity. The first tip is planting the seed and committing, and hopefully your attendance today is that seed if you haven't even gone further. But also self-reflecting as an organization, engaging with stakeholders and communities, partnering, collaborating, getting out there and seeing what the needs are, putting a plan in play, putting it in paper, implement it, and continuously monitor. There's fluidity in these steps, so we can always continue to learn and grow. So now that we've looked into our personal practices, we can imagine how we present ourselves and put this puzzle together from earlier, the photos that I shared. And we're going to do so by looking at positionality statements. So positionality statements, it is a world view, if you will. Where are we coming from? It is informed by an individual's values and beliefs, shaped by gender, sexuality, historical and geographic location, ethnicity, race, social class, religion, faith, spirituality, political allegiance, disability. I mean, I'm going through a lot here, but all of these make us who we are. And this can be something that we can present as ourselves and also to others in terms of how we provide research and how we provide programming. In research, position is how a researcher might adopt within the project. What position are they taking within a project? It influences how the project might be conducted. It might influence the outcomes and the results. So there's an awareness there. Be aware of how positions may impact the participation in research projects or in settings where we're giving more of a service delivery. The influence of insider-outsider standing, acknowledging advantages, disadvantages, implications for the process of data gathering and interpretation. And if you look at this list here, you can see that it's integral in qualitative research, but that's also something that can really be utilized in terms of how we develop programs and collaborations for service delivery. So a researcher or an individual's positionality is not fixed. It's a reflective practice in articulating one's positionality, and it may assist in becoming a better researcher. I would go on to say it could even influence how we become better at collaborative partnerships and how we become stronger within our community. So my positionality to share here is that I'm a white, heterosexual, cisgender female, come from a middle-class background. You saw a little bit of my background. I have access to economic resources and a high level of education. I'm doctorally trained, and I work and choose to work in the nonprofit sector. In terms of my perspective, there's some additional components to who I am. This is the lens I use in my professional work. This is me on paper, but I'm so much more, and I bring that to my relationships and my collaborations. You saw a glimpse of that at the beginning of the presentation. So using the concept of positionality statement when stewarding relationships, what that can look like is applying positionality statement to authentically engage in the community and with your community partners. Build complementary partnerships and learn and grow from one another. So this is just some information. It actually comes from LinkedIn article, and this is a human resource professional. I wanted to get the idea of human resources, tying together those factors of building collaborations and being leaders. And this really comes to light right at the top is the idea of trust. So as a building block for collaboration, incorporating trust, vulnerability, communication, self-awareness, and commitment. And that can lead to change. It can lead to information sharing. It can lead to dynamic listening, being empathetic listeners, hearing one another before moving forward. Negotiation and flexibility can also be included. So you can see how authenticity and transparency can support community engagement and collaboration. Rather than coming in as an expert, come in as equals and build something together. Knowing our challenges and being open to share, to learn, and to gain insight. Now, in terms of applying research standards to collaboration, so I just really want to quickly draw from the standards that we have in place that are built into research designs and see how that might influence how we can build collaborative partnerships and community engagement. And to do that, I'm going to look first at the Human Subjects Research Guidelines. So this comes from the Belmont Report. So if you have any experience with research, you have probably done a human subjects training. And this comes right from there, the ethical principles and guidelines for the protection of human subjects in research. And this was established in 1979. So the respect for persons requires researchers to assure autonomy and protect those with diminished autonomy. Allow those who can to make informed choices about taking part in research, and by instituting added protections for those who do not have the capacity to decide. In diverse communities, this can only be accomplished when information is tailored to the subject's linguistic needs, it's comprehensible, and it's delivered in a culturally congruent manner. So considering that respect for persons as it's laid out with research, how would that influence how you might incorporate collaboration? How might you partner with somebody in the community or another agency, a leader in the community, a church group, another healthcare provider? There's a lot of ways that you can consider this. In terms of beneficence, this requires favorably balancing the risks and the potential benefits for participation. Risks including physical, emotional, economic, stigmatization, confidentiality. So weighing those out to how the benefits of the participation in research might be for that individual. And I think this applies also to how we incorporate and start to embed services into the community. Researchers need to engage community leaders in the process of estimating risk-benefit ratios to gain full appreciation for how participation might affect individuals participating in studies. And this is also true for what we do with collaborative services. And then looking lastly at justice, this is for individual requires fair recruitment practices. Social justice requires decisions be made by researchers in light of the ability of certain ethnic and economic classes to bear added burdens of research. Disadvantaged groups should be protected from being asked to participate in research for the convenience or for the socioeconomic status. So consider how this also guides the community collaboration efforts. And use caution. Caution is required in research. Trust should be a first step for interventions and practices as well. Additionally, when conducting research with diverse communities, we're looking at how to involve community members in decisions about key aspects. This is promoting feelings of ownership within the community, maintaining public accountability and transparency, assuring appropriate ethics oversight, and again, building that trust. And this is also threaded through when we introduce the community-based participatory research and how these elements can be considered in partnership development. Also, coming out of how research can be conducted with diverse communities, or all research for that matter too, is how we disseminate the results. And this is to really make improvements in public health. So when working with communities, we want to make sure that we share the findings with stakeholders within the community. We can get literature into peer-reviewed journals, but we can also disseminate it through educational programming. We do a lot of programming here at CSC Los Angeles in order to assist those that are either conducting research in the hospital system throughout Los Angeles to get their findings, their outcomes out to the public, but also to use as a recruitment tool and to educate the public prior to starting research. So there can be some buy-in and some trust building on both sides. Okay, so now to just give some samples of existing evidence to support collaboration and partnership, and this comes in the mental health area as well as oncology care. So this comes in this is a phenomenological study from medical providers. So this is outside of cancer, but it does have the utilization of medicine as well as mental health. For this study, 18 medical providers from diverse settings were interviewed about their experience in collaborative healthcare settings in which mental health services were integrated. And using the phenomenological model and that approach, they identified 5 themes that had emerged that served as benefits and or barriers to the delivery of the collaborative healthcare. One being time and resources, proximity of access and collaboration, collaborative mental health literacy, stigma, and finances. To dive a little deeper, stigma was the impact of mental health stigmatization as a barrier to accessing care. So they recognized that as a theme. However, the medical providers identified that working in collaborative health settings reduced the barriers. It gave immediate access. And this, as a follow-up to Dr. Jennifer Kelly's talk, was really embedding services where people want to go, was a recommendation that came out of how to make more equitable healthcare services available. So this is a finding that also supports that, is to embed those services. Benefits and barriers were linked so that the benefits mitigated the impact of the barriers on the respective themes. 2 exceptions were the barriers related to availability or scheduling and the other financial barriers. The recommendations coming out of this study was that healthcare settings that offer multidisciplinary cohesive care demonstrate improved treatment continuity and patient outcomes for both physical and mental disorders. Collaborative healthcare approaches improve provider and patient outcomes and access across diverse clinical settings in an overburdened system. So the collaborations actually created more access and were able to be conducted even in systems that were overburdened. And mental health services should be offered in the same location as the patient seeks out medical treatments was also a recommendation coming out of this study. What that means in terms of what we do here at Cancer Support Community is also the idea of collaboration and how can we ensure delivery either on-site or off-site, and how can you build your own services within your system for mental health. Another study to look into, and this does look at oncology in the area of pediatrics, was from SuperSibs. And I remember using SuperSibs, and we still have that as a resource here for our pediatric clients and their siblings. But it's a national organization, it's a nonprofit, and their mission is to ensure that siblings of children with any type of cancer are supported, honored, and recognized so that they can face the future with strength, courage, and hope. So although most community partner research occurs at a local level, the community can encompass a geographically diverse cohort. So they're identifying diversity and community as this large geographic area of individuals experiencing childhood cancer. So this was a partnership that they developed across multiple healthcare systems. And the lessons that they learned were, one, to realize a shared mission. So they utilized what they called a sibling research advisory board. They partnered with multiple academic institutions over an 8-year partnership. The cohesiveness was fostered by intentionally creating a culture of collaboration. And their second lesson was to balance research and service responsibilities. So the involvement in SuperSibs was neither contingent nor related to the research enrollment. So individuals could participate in the research, but it did not hinder if they chose not to be in the research, that they could still utilize the resource and the service. And then 3, to ensure sample representativeness. So recruitment through community organizations may reduce the degree to which a sample resembles the broader population. So a second question that they identified here in terms of also what steps for future research was whether families who enroll in the research resemble those who decline. So in terms of community groups or researchers seeking to establish partnerships, they're included to do these recommendations from the SuperSibs partnership. And that's to identify partners committed to establishing empirical support for community-based initiatives, develop shared goals, use goals to inform a partnership mission for short and long-term objectives and strategies, and to frequently assess progress and modify their approach as needed. And in the nonprofit world, this looks very familiar, to identify sources of ongoing financial support. So did you hear some threads that might have been similar to the community-based participatory research and to how partnerships can be developed and continuously monitored? And then, yes, looking back to that CDPR, we can see that community-based participatory research projects are used to inform action within the community, and that the findings should inform community efforts and incorporate change. So coming from those 2 projects that we looked at, and then looking here as how the CBPR recommends for dissemination, we want to look a little bit further into coming from these tenets of CBPR into actual dissemination and implementation and what that means. So dissemination is an active approach of spreading evidence-based interventions to the target audience via determined channels using planned strategies. Implementation is the process of putting to use or integrating evidence-based interventions within a setting. And then a final area here to consider is reach. And that's the ability of a program to engage its ultimate target audience. Are you reaching those that you're hoping to reach or you're expecting to reach, both in terms of quality and quantity? And this is going to be a great influence to public health and make an impact on public health if done correctly and successfully. So these each come from the Dissemination and Implementation Research in Health second edition. And I'm going to dive down a little bit more into this book. And this is the authors of Kirshner et al. And these are the different strategies for implementation. So to go through quickly, it's to use and evaluate integrative strategies, provide interactive assistance, adapt and tailor the content, develop stakeholder interrelationships, train and educate stakeholders, support clinicians, engage consumers, utilize financial strategies, and to change infrastructure. That is a lot of information, and I do encourage you to look back at the dissemination information research findings and information. But for the sake of our talk today, I'm going to focus on developing stakeholder interrelations. So here are some points, and these are expert recommendations for implementing change. This came from the EPIC project. And to give a little detail to each of these, I think I lost my slide. It's to develop academic partnerships, partner with a university or academic unit. I would say that you can add a community-based organization or any kind of organization within the community that supports the population that you seek to work with. Identify and prepare champions, involve executive boards, involve governing structures. There's board of directors, there's medical directors. We could add the idea of community-based advisory boards, professional advisory boards. We also have a Cancer Equity and Diversity Committee. Obtain formal commitments, get MOUs, get contracts, make these agreements formalized in terms of your partnerships. Promote network weaving, build on existing relationships within and outside of one's organization. So promote information sharing and collaborative problem solving. Work together. Recruit, designate, and train for leadership. This is, you can lead change. And we looked at that. We looked at even how post-traumatic growth can be really influenced by leadership, especially coming out of COVID. Use advisory boards and work groups, and that can be a way to engage multiple stakeholders to provide insight and guide implementation, and to visit other sites, see what's successful out there, and learn from each other. And I would add too, that's also another way to identify another partner and steward a new relationship. With that, I'd like to take you into the collaborative research and practice that we have here at Cancer Support Community in Los Angeles. So this is Cancer Support Community. We look a little different now. We have been very virtual, and we're just starting to have some in-person services return. But this is what it looked like coming into our community space. And all of our CSCs and Gildas clubs across the country and in Canada, and we have 4 international offices actually, they have that same mission and model: to empower with knowledge, to strengthen with action, and to stay with the community. And I welcome you to come and visit if you're local, or if you are not in the Los Angeles area, find a CSC or Gildas club close to you. In terms of the work, this is kind of a brief overlook, a very brief overlook at the services that we have in play. And we look at it sometimes across different pillars, those being our emotional support, which is group support, counseling services, educational workshops, healthy lifestyle classes like Qigong or yoga, or have Nordic walking in the park, many mindfulness and meditation classes. We also have social activities and a child, teen, and family program that mirrors all of these areas. What's not on here is our resources and how we can be a resource as well as share resources. So we have a long list of other community organizations, other hospital services, other nonprofits that do similar work, that are like-minded, like-missioned, and how can we share that? So if somebody contacts us, we hope we can fit their needs, but we also have many other opportunities for them to get engaged and get support. And to share a little bit about the internal culture, we spoke at the beginning on that leadership piece and what it was like to pivot during COVID. And this slide actually came from a talk that I shared kind of early on in COVID. And this is when we really recognized who we were and how we could be internally as a staff. We are a small administrative staff. There's usually 7 or 8 of us, and we have about 25 in total, and that's inclusive of our licensed mental health providers across disciplines of psychology, marriage and family therapy, social work. We also are a training institution, so we have those same disciplines that are trying to get through their graduate programs or into licensure. And what we recognized during COVID was also the need for us together to promote acceptance and to encourage flexibility, to welcome vulnerability, and to model resilience. And us being able to work together and to have that as an expectation for ourselves was a way that we could set up and design our expectations for those that use our services, to be more flexible when those who are accessing our care might not be able to be here every day, might have hiccups with their internet. How do we look for grants to offer internet and hardware tablets? How do we think differently? As an example here to also highlight leadership change in the promotion of post-traumatic growth versus that stress. We were just going into a clinical team meeting, so it's much like a supervision or consultation meeting that we have with all of our licensed and unlicensed clinicians. And we were just going into our meeting around the same hour of the January 6th riot. And that was a lot of stress. There was multiple inputs of information, a lot of technology happening. There was TVs were on and phones were ringing. And if there's notifications on your phone, there was a lot happening that day. So it was to not go into our typical meeting, but to make space. We did a breathing exercise and a guided imagery exercise together to center. And we had the ability to knock off that meeting. If you did not want to attend, don't. Do what you need to do for you right now. And we actually all stayed in the meeting after doing that imagery and breathing exercise. And we were able to actually support each other when this was happening. And I think that is a really great way to illustrate just how that acceptance can be. We're in this together through the pandemic. And if you were at Bill's talk, you saw that Bill has had personal experience that led to his being a provider of care for cancer. So we can't take ourselves out of it, but we can really start modeling these sorts of healthy internal structures and cultures in the way that we do our work. And this applies to how we collaborate with others. In terms of external collaborations, we co-brand support groups and services. During COVID, we even did more educational presentations. We had a wider, more diverse audience because we didn't have to be in person. We were able to join hospital team meetings. We did conference presentations across APOS, the SoCal Women's Conference. We had English and Spanish presentations there. We recently did an equity, diversity, inclusion clinical trial training, and this was a global conference. And these are elements that we would not have access to if we did not think about how the virtual technology can support our collaborations. Although I am looking forward to doing some in-person work, and I've been to a couple of conferences recently in person, so I think there's change happening. And then lastly, you are here at our Health Equity Summit #2. Last year was the establishment of our inaugural Health Equity Summit, and that came out of the ability to kind of share what we know in a way to give service and education, but also as a fundraising arm to the work that we do here at CSCLA. And that also came out of thinking differently and collaborating differently. In terms of external collaboration, we also increased our attendance. We had targeted and specialized programming. We were able to reach more people because they did not have to be here. Prior to COVID, I remember having a very small group of people for a myeloproliferative neoplasm event. And we had about 10, 12 people in there. And someone said to me, this is the first time I met somebody with my same diagnosis. and thinking about how that can shift to the use of technology and having many, many people join together and being able to connect with others like them. We created a SoCal initiative, and that's how we work together throughout our SoCal area here. I have 3 other sister sites. So we work together. We are CSC South Bay, CSC Pasadena, CSC Valley Ventura, and CSC Los Angeles. So how do we collaborate? We also recognize the strength of programs in virtual space, like I said, and that was utilizing a video library, which is growing by the day. And at the very early part of COVID too, it was kind of contraindicated to have minors on telehealth. So we created videos with wonderful activities, therapeutic activities that could be done with the family. So how do we think a little differently? This is just a snapshot, an overview of our strategic plan that we have here at CSCLA, and this is 2022 through 24. And I'm just going to highlight the large goals, which were and are to expand impact, build capacity, engage communities, and be fiscally responsible. Looking at the engaging communities, we have the goal here to increase access and delivery of high quality, high value services and educational programs to communities in need. And the strategies that we've developed here, you can see, I just wanted to pull out 2 really important pieces, which is to steward relationships and to implement justice, equity, diversity, and inclusivity framework across all of our program development and administrative operations. That's included here in this goal, but it is threaded through the entire strategic plan. So what that looks like, engagement of a community advisory board. We have a professional advisory board for those that are leaders within oncology and supportive care, but also our Cancer Equity and Diversity Committee. So this is individuals throughout Los Angeles that can really share their voice to the work that we're doing. And we're also proud to be participants in the Cedars-Sinai Community Advisory Board, City of Hope Community Outreach and Engagement Community Advisory Board, as well as the UCLA Johnson Comprehensive Cancer Center. They have a Clinical Trials Equity Advisory Committee. So these are ways that I encourage you to either lead and have an advisory board of the work that you're doing or participate in another's. This is a quick visual of how we think about our program delivery across different populations and how we can ensure that we do not have gaps. We want to grow in these different areas. And our HEART program is healing equitably through action, resilience, and teamwork. This is actually just the way that we consider how to partner across Los Angeles and beyond, with a list of some of our current partnerships. And then to finish up, I just want to show you some of the different work that we're doing collaboratively. So this is Sister Friends, and Yolanda Whittington is actually going to be on our panel, I believe, tomorrow. She facilitates this group that we do collaboratively through Sister Friends, and she's the founder of Sister Friends. She's leading the Black Women Living with Cancer group. And this is online, and we have a goal to also offer something in person at Sister Friends. Frankly Speaking About Cancer is a evidence-based platform for multiple different types of education programmings. It comes out of our headquarters. And Frankly Speaking About Cancer, we did a cost of care. This was in Spanish with one of our providers. And we have a new program coming soon that's going to be in Spanish. It's going to be in person at White Memorial Hospital Medical Center, as well as online for those that can access it that way. More to come. We're very excited to be partnering with our sister affiliate, Gilda's Club in Madison, Wisconsin. And this is also through some sponsorship from Grit Health. This is our young adult game night. So out of requests from individuals accessing our young adult services of needing more social time and social engagement, we created this game night, and it's incredible. We have some special guests coming soon. This is a recent event. This was at the zoo, and it was wonderful to be in person. And we are very grateful to Dr. Aura Cooperberg and Shu at the Adolescent and Young Adult Cancer Program at USC for the invitation to participate in their family event in Zootopia. This was an event where we were able to come, myself and 2 of our clinical associates here, to provide a therapeutic activity with the children and teens. Digital Sherpa, you might hear more. This is growing and coming soon to different areas of how we can link those that are in volunteer, coming maybe from some of the universities in the area, to support those that might be in the older populations with technology, and kind of have this kind of intergenerational training and teaching to support people in getting connected through the use of technology. We're also working with Dr. Maria Garcia Jimenez, and she has a cancer clinical trials program that she's putting together through UCLA and all of you. We're very excited to be participating in that, and this is also going to be all available in Spanish. And lastly here, this is just to highlight a recent caregiver initiative that we had, and this was collaborative not just through Providence St. John's CSCLA and through the gracious support of Tower Cancer Research Foundation, but it was a consortium that had leaders throughout LA that came together to design this content on becoming a mentor to cancer caregivers. So with that, I will share my contact information, and I hope you take note of this. I want you to reach out. I want to work with you. And we're very excited for the collaborations we have in place, but also looking for those that are coming next. So I look forward to hearing from you, and thank you very much.
Thank you so much, Dr. Cava. That was a wonderful presentation, and I love the pictures and the sharing of your personal story. And I think we all have that awkward school picture. I don't think there's a person out there who doesn't. Maybe they are always wonderful at taking pictures, but I definitely have that awkward picture. So I do want to remind all our attendees that you can add your questions in the Q&A feature. But my first question to you, Dr. LaCava, is like, we know building trust is of the utmost importance when building partnerships. So how do we ensure that that trust is maintained throughout the process? So what happens when that trust is broken? How do you repair it, and can it even be repaired?
That's such a good question, and I think there's a few questions within that. So as some of the literature really speaks to reevaluating, continuously monitoring partnerships, right? So that, I think, if you're able to establish trust, which there's a lot to that piece, right? And I think is, how do we come as our authentic selves into a relationship without being the expert, with really coming to that collaborative and equal parts building of a relationship, stewarding of a relationship. So if you get to that place and you have this trust built, in terms of keeping that trust, I think that comes in the work that we provide and who we are and how we show up in our partnerships and how we communicate it, whether it be within a community, how we keep engagement, how we, whether it be research or service delivery, how do we really keep that engagement and listen to the community? I didn't get a chance to explain on our Cancer Equity and Diversity Committee. The name came out of, if you call it SED by its acronym, SED in Spanish, and you can probably speak more to this than I, but it means thirst. So this came from our community advisors to not just say we need people to come and help and provide resources to under-resourced areas, but we want a voice. We want to share what works in our community. We have strengths that we think need to be highlighted, and that's how we can learn. So I think having that voice and continuing the relationship that way is a strong way to keep that trust and to keep that relationship strong.
Wonderful. Thank you so much. And we have a question for you from the attendees. And the question is, what's the most important lesson you've learned from engaging in community-based participatory research?
So in terms of my lesson there, I was so excited. So it was years ago, I participated in a quick start study. And I advise any of you, if you are able to join a CBPR training, the quick start training program, if you Google it, it is a very intensive training. In the past, it was in person, a couple days here in Los Angeles and a couple days up at Berkeley. And it was a wonderful way to learn all of the ins and outs of community-based participatory research. And I put together, at that point, there was a couple of us to put together a grant. We were unfortunately not funded, but what I took from that was I used threads of community-based participatory research, and it is a mouthful. I don't think I've ever gotten to master how to say that quickly, but I've used that as how I inform the work that I do daily, because of what the meaning is on who we are as we show up in our work, and also how to engage. To consider the idea of a closed mouth is never fed. How do we get out there and work together? And I think it's kind of like two heads are better than one. So if we're trying to look at an issue or a problem, I think it's good to work together and brainstorm that way. The same as how do we get the services where there's need? And I think that's looking at what can we do together, back to Dr. Jennifer Kelly's question, or how can we do it? I mean, we can do it together. So I would say in terms of community-based participatory research, it's threaded in research collaborations and as co-PI on other projects. And it is really part of how we do service delivery and how we grow our program.
Wonderful, absolutely. And our next question asks, what advice do you have for cultivating relationships with community collaborators?
Getting advice with community collaborators. I think it's just that humility, right? And I think if there's an honesty to how we engage in a relationship, and if in the thread of positionality statements of working with others that may complement ourselves, I think it's all about being a complement and what can I bring, but how can I be humble and ask and be transparent about what I don't know. I showed some awkward pictures of myself to just show that maybe we don't always have to have that perfect component of how we present ourselves. Maybe we can be, warts and all engagement and be able to model that we also trust that other person and aren't judging in any way. So I think that's how we can come into those types of relationships.
Absolutely, yeah. And you know what, I have one more question for you. And so, you had mentioned this in one of your answers that what was the saying, that a closed mouth is never fed, right? And so you're basically saying, ask for help, get out of that comfort zone. But what would you say to people who maybe feel like they don't have that confidence to get out of that comfort zone? What can they do to build that confidence so that they can get out of that?
Oh, good question. That's a good question. I would say, start small. Everything is like a baby step until you learn to walk, right? So maybe it's not reaching out to somebody that you've had no contact with a grand question that is really, really out of your comfort zone, but how do you make small requests? And I think sometimes even taking inventory in the conversations and the dialogues that we've had, we can recognize where we've done that already. How did we get to the role that we're in? What's our favorite thing about this role in this position? What do we want to do with it? How do we want to collaborate? And sometimes that can guide us a little bit, but start small and trust yourself. And I think the one thing that was kind of provided some comfort for me when I started thinking that way about the closed mouth is never fed is what's the worst that can happen, and not to catastrophize, but someone can say no. And thinking, okay, well, I can manage through that, right? If someone says, no, I can't make time, or no, I'm sorry, I really am not able to do your request, I can handle that. And I think the idea of making the effort to connect, it should be received well, even if the answer is no. And I've actually been really, really successful, because I will say on the flip side of being someone who I enjoy mentoring, I like being a supervisor clinically. When someone comes with a request that's really personal to the work that they're trying to do, to their professional development, and it might not be in response to a large didactic, but I just wanted to ask you this thing, or I wonder if you can help me here, or do you have any ideas about this? I'm pulled from that because that's something that I want to do. And I think if we put ourselves in that shoes and who we are and how we would respond to a question, that I think gives us the confidence to be able to make some more of those asks.
Wonderful. Yeah, that's some great advice. I know not all of us are comfortable. We do fear that word no. But yeah, I love the mindset that it's what's the worst that can happen, right? Although that idea could get out of hand, but you're right back where you started, right? If you never asked, and somebody says no, that's where you started anyway. So it's worth the risk. And we do have a participant that's asking if you could please repeat the name of the foundation, the one that was it Black Women Living with Cancer.
Sister Friends is the organization that we're collaborating with. Yes. And so that is a nonprofit that offers mental health services to women and men in the Black community. And we're
wonderful.
And Yolanda will be here as well tomorrow if there's more further questions.
Yeah, and I don't know, maybe perhaps if there's a website, maybe we can add that link somewhere so that people can have access, or maybe with our speaker tomorrow. So maybe please join us tomorrow, obviously, to learn more about this organization and the wonderful work that they're doing. So with that, I want to say thank you so much, Dr. Cava, for sharing your expertise in community-based participatory research, and we can just call it CBPR now for short so we don't get tongue twisted. But thank you so much. And we want to thank everybody for spending this morning with us. And now we are going to have 1 hour break for lunch, and we're going to return at 1 o'clock with our panel speakers.
Our immense thanks to Cancer Support Community. We know that your motto is, so no one faces cancer alone. Boy, do I know what you mean by that.
Being diagnosed with cancer is one of the most difficult things that a person and their family can go through. The spirit of the mission of Cancer Support Community is that no one should face cancer alone.
When you come through the doors here, it is the most welcoming setting. It's like coming into a friend's home. And you don't have a feeling that you're going someplace because you're sick. You're going someplace to be with your friends. And that's what it's all about.
My father's name was Harold Benjamin, and he was the founder, along with my mother, Harriet Benjamin, of the Cancer Support Community, previously called the Wellness Community. Mom got cancer, and they realized that actually going to support groups made such a difference in her recovery. So my father decided that he would create this organization that would really make a difference in the lives of people with cancer and their loved ones. Gilda Radner came to the organization. She was so excited about how this changed her life. When Gilda passed, Gene Wilder and a woman by the name of Joanna Bull decided to start Gilda's Club in New York City. Several years ago, the Wellness Community and Gilda's Club joined forces.
We are a community, and we sustain each other through community. Aside from the services that we give, this is a very important gathering place of hope and support for people.
We laugh a lot in the groups, we cry a lot in the groups. I've made incredible lifelong friends.
I did not know that I was going to live. And I met someone in the group who had been alive for 7 years. Same tumor grade, same location, and had been alive for 7 years and had 2 kids, 2 little kids. And I needed the imagination to know that I could survive because I was so certain I wasn't going to.
When I got the news, I think I was numb, and it got really challenging having to break the news to my family because I didn't know how they would take it.
Until we are able to get rid of this disease once and for all, it's nice to know there's a lot of support to help you get through it.
The people that I've met here, I will be friends with for the rest of my life. The things that you could talk about are very personal. It's a safe place. When you get in a group, you realize that your problems really aren't that bad. I would not be here today if it wasn't for CSC.
We had cancer. It is true that he was the one who was having the treatment and the existential experience. But in my way, I did too.
I finally broke down and decided to come into a walk-in group. You can't talk to your own friends in the same way because they really don't understand. I need as much help as Linda in a different way, that's all.
I passionately believe that the cure to cancer is not just the medications and the treatment that they give you. And what we found in the support center here is this amazing experience of being able to come here, find all those other things that make it a holistic treatment.
We have 5 pillars of support: groups and counseling, healthy lifestyle classes, educational workshops, social activities, and child, teen, and family programs. All of those pillars work together to create a holistic way of supporting not just the patient, but the family members.
We have calendars that show all the events and classes here. I've taken advantage of the group therapy, one-on-one, yoga, the lunch and learn workshops, educational things here.
No matter how I'm feeling, I pretty much always drag myself on Wednesdays to the writing group. It's a really amazing, supportive community, and it's really neat because it's one of the groups here at the Benjamin Center that can be combined of both caregivers and patients, which has really helped me to understand my partner's perspective through this, hearing some of the caregivers writing.
I walk through these doors and there's people, Zumba music dancing and people smiling and having fun.
I have discovered the celebration circle. That's a wonderful time just to get together and think about the good things that are going on in your life and to express gratitude and not so much dealing with the cancer all the time. And it's a time to sort of fellowship over good food and good conversation and really having a time of just celebrating the life that we have.
I think that once people find out about this community, I'm hoping that they will be generous with their donation, because everything for the patients here and for the families is free. And we depend on the generosity of people who have the means to give back.
What you do more than any organization in the world is you give a sense of hope. Even if it's just one more day, one more week, one more month.
We really appreciate your donations. We appreciate your concern and commitment to this organization.
I think that's the true definition of love, when you can love someone or do something for someone that you don't know. Thank you.
I just want to say thank you, because it has given me like a family, and being able to connect and meet such amazing people like that in this space is just such a gift. Like, you're really giving people a gift by your donations.
Now that I've gotten through what I hope is the worst of it, I can look back and say that the cancer support community was one of the joys that this experience has brought to my life. So thank you for allowing me to have that experience, for giving me another place I can call home.
So today, our roundtable is made up of experts that are working in the community, working in the health equity field. But they're also focusing their work in behavioral health, right? And in making sure that we're addressing all of the needs of our cancer patients and their caregivers. So to start off, our panel is going to consist of Dr. Caryn Whitacre with the Los Angeles LGBT Center. We also have Rhonda Smith with the California Black Health Network. We have Sylvia Ferullo Lopez, formerly with UCLA Johnson Comprehensive Cancer Center. Dr. Shannon Cava with Cancer Support Community Los Angeles. And last but not least, we have Dr. Ghecemy Lopez with USC Norris Comprehensive Cancer Center, Keck School of Medicine. So please welcome all our roundtable speakers and panelists. Welcome, everyone. So we're going to start off with some questions for you all. So I'm going to, I hope you were able to join us this morning to see, the wonderful speakers that we had and the topics that we covered today. But we wanted to focus a little bit on some of your area of expertise and your area of work. So I'm going to start off with Dr. Caryn Whitacre. Dr. Caryn Whitacre, what is disenfranchised grief? And how can we, as helping professionals, support those experiencing disenfranchised grief?
Thank you for asking the question, and thank you for having me here today. As I was watching the opening video, I found myself so moved. It was so beautiful. And thinking about what grief looks like and the importance of having that having that support is everything. And disenfranchised grief is really profound. We know that there are many different types of grief, right? There's a long list, and we all experience it in very different ways. But disenfranchised grief is a type of grief that we experience when our loss doesn't necessarily fit into society's ideas, right? Our loss isn't seen as accepted. It's not something we can openly discuss. And because of this, it creates a lot of complications around grief processing and how to move through the experience. And it occurs for a variety of reasons. So, it can be the circumstances around the death. It can be related to the stigma that is attached to the experience. And, as a clinician at the LGBT Center, this is something that I find myself providing support for on a regular basis, because so many of our community members have had this experience. Their loss isn't seen as real, or their relationship isn't seen as meaningful, and it creates such distress for our community. And so, I look at it as a privilege of being able to be on this path, with those that are grieving, with those that are trying to find their way through. And so, in providing that support, through the years, I've been doing this for a while, and I've learned that one of the most important interventions is really just to be there, right? To allow ourselves as professionals, as clinicians, to bear witness to that pain that's being experienced. One of the most important tools that we have is listening, and we know that as professionals, when we're able to provide our clients with that safe space to talk about their loss without judgment, without the bias, and to just share in their story, we can think of that as really providing them with a lifeline, an opportunity to start to heal. And so bearing witness to the pain that's experienced by others, it's not an easy thing for us to do, but it's one of the most important things that we can do, for one another. So we need to be mindful of those differences that exist between us, and remember that one person's experience of grief is not going to look the same as another person's, and that when we can acknowledge a person's loss, we're giving them an opportunity to feel safe and to feel supported.
Yeah, it's really that importance of validation, right? And because what we tend to do is compare grief, right? It's like, well, I don't have it as bad as that person, so I shouldn't be feeling this bad. And, I know, I don't know if I've gone through that, where, I start comparing my grief, and maybe I shouldn't be feeling this bad because somebody else has it worse, but there's no comparison when it comes to grief, right?
Yeah, absolutely. And the reality is those shoulds, that's the judgment. And however we're feeling is how we're feeling, right? And to be allowed to just have that, to be able to help hold a person where they are, and to just know that, yeah, today is a bad day, right? And I don't have to sugarcoat it or look for the silver lining or engage in that toxic positivity, right? Today is hard. So how can I support you? And finding the language to provide people with that opening, right? And instead of feeling like we have to fix it, being able to just ask, like, how can I support you today? Mm-hmm. And that can make such a difference for people.
Thank you so much, Dr. Whitacre. Those are some insightful tips, for all of us that have to, deal with grief. And I love the idea of, that toxic positivity, right? That sometimes it's okay to not be okay. Yeah, and, exactly. We don't always have to be pushing, to make it, push through it. So thank you for reminding us of that.
Absolutely. Thank you.
So I'm going to ask our next panelist a question, and this, Sylvia, question is for you. And so what are some ideas for improving mental health services for members of the Latino community affected by cancer?
Thank you so much, Myra. And it's such a pleasure to be here. And I want to clarify that I am not a clinician myself. I worked for 4 years at a comprehensive cancer center at UCLA, supporting cancer research and doing community outreach. And, you know, the solutions, I think that we've all heard about the disparities that are faced by different communities, different groups. The disparities that are faced by Latino cancer patients are challenging. They are complex. It will take a lot of meaningful reform, but I think that there's some broad areas that we have to talk about, starting with investing in public health programs to raise awareness and normalizing use of services, which is something that is very hard for a lot of Latinos. Programs and trainings and sessions like this one for providers and boots on the ground staff and clinicians who can, you know, are always trying to learn, but have more to learn from listening to others. Increasing the diversity of our healthcare workers is extremely important, and promoting research opportunities that are inclusive of Latinos. You've probably all heard that while we represent nearly 20% of the population in the US, we're only like 10% of clinical trial participants and 4% of participants on FDA drug trials. And then institutional programs and different policies that really improve cultural competency, which are so important, and system level interventions to promote screening, to promote management, to promote screening, I'm sorry. So these are some of the ideas, and I think that there's a lot of specific things that we really could, if you want to get into the weeds, talk about, like more culturally concordant programs and in-language programs, culturally sensitive and linguistically appropriate health education and information, specific programs and opportunities for early career development and mentorship for Latino students. One of my favorites is hiring more trusted community members, such as promotoras de salud and community health workers who really have that shared cultural experience and understanding. Engaging community organizations such as churches, where we can hold events and partner with them to provide safe places for people to go and connect with. And then again, just sustained community-based engagement and investment in education and other programs that really have potential benefit for our patients, for providers, for clinicians, for all of us.
Wonderful. Thank you so much, Sylvia. And I love that idea of the racial concordance and maybe promoting more health care workforce that looks like the population we're serving. I know one of the first things when I was looking for a therapist, I tried to find a Latina, right? So that, you know, I didn't have to go into those cultural nuances when I was explaining things. I wanted her to understand my family structure, my culture. And so I figured, you know, instead of explaining that to them, it'd be better for me if I found someone that was from that same culture and could understand all those things. So I really do appreciate you bringing that up. And the idea of using trusted community champions, right? Like the community health workers and promotoras, because people tend to, you know, those are people that have established trust, as you mentioned. And so especially when it comes to something like accessing services where there could be some mistrust or, you know, you need some navigation, you know, that having community health workers can really help with that. Now, that being said, Sylvia, are there any signs at all to the way Latinos perceive mental health services that might be changing?
You know, there are some positive trends. Again, I'm not a clinician, but I see myself more as a storyteller, not only of my own stories, but of other people's stories. And so whenever I'm asked to talk about something, I always try to gather as many stories as I can. And I was talking to a clinician up in the San Jose, Santa Clara County area, and she works with an organization called Latinas contra el Cáncer. And they do a lot of different outreach and groups for cancer patients and caregivers. And what she told me was that while, you know, the stigma of mental health and mental health treatment and illness has always existed in the Latino community, as it has in others, In the Latino community, it is a huge stigma, you know, especially among older Latinos. Like you hear that myth that like you're crazy, you know, if you need any sort of mental health services. So what she told me is that really seems to be fading a lot with the younger generation, that young people are much more willing to seek out help, to discuss mental issues openly, to name those issues. And, you know, maybe that's because we're seeing more of it and people are more open about it, and they've been exposed to more of it, perhaps in their early education, but she sees that's really changing a lot. She also told me that Latinas contra el Cáncer has opened, so a little history, they always have done Spanish language services only. And recently they've opened an English speaking group, even though they historically support Spanish speaking patients. And I think that this shows a couple of things. One, the importance of having that shared cultural understanding, regardless of language, is really important for people. So even if they speak English, they still want that shared cultural understanding. And also that an organization like Latinas contra el Cáncer would be able to expand their programs to outreach to English speaking patients, which is sort of the reverse of what we've always seen, which is English speaking organizations branching out to Latinos. Kind of, I don't know, to me, it's a nice sign that, you know, they're expanding, they're able to expand, they're able to do more outreach, maybe to first generation Latino people. And then also the final sort of positive trend is that Zoom has made it so much easier for so many people to attend. And I know that's true for many different ethnic groups and diverse groups, but for many people, COVID really helped them get to the forefront of technology. They had to learn it, and it was a long learning period, but they did, and they finally are on board. And also the Latino community has really embraced the cell phone. That's really important to Latinos as it is to many people, but they have embraced it. And so they will find a way to use it in any situation if they can. We did a training when I was at UCLA on vaping prevention, and we found promotores and different people were taking their cell phone and going and sitting in front of libraries to, you know, overcome the broadband and connectivity issues. And they were just finding those hotspots wherever they could and making it work. We had people that were walking through quinceañera conferences with their cell phone in their hands, trying to do the training at the same time that they were shopping. So, you know, for them, it's something that seems to be coming very naturally now to kind of take it with them wherever they go and do the training wherever they are.
Wonderful. Thank you, Sylvia. And one of the participants is asking if you could repeat the name of the organization that you mentioned that was in San Jose.
It's Latinas contra el Cáncer. So Latinos against cancer. And, you know, and I did want to say that on a side note, I was talking about increasing culturally concordant services. In preparation for this panel today, I just kind of did a Google search of organizations that provide cancer support to Spanish-speaking patients. And of course, Cancer Support Community came up in Los Angeles, and WeSpark came up, you know, which is awesome. And we're so fortunate that these groups are now providing services in Spanish. But there was nothing else in the Los Angeles area that came up with kind of a more of a culturally resonant name. I did notice that in the San Jose area, you have Latinas contra el Cáncer. In the Chicago area, you have an organization called ALAS. In the DC area, you have an organization called Nueva Vida, which I think those names naturally draw people and probably make them feel a little more comfortable about attending. I'm sure once they come to Cancer Support Community and WeSpark, they will be very well welcomed and taken care of. But that just shows you, I think, that, you know, think about the millions and millions of Latinos we have in the United States and Los Angeles in particular. And there really aren't, there are very few, you can count on one hand the number of organizations that have made it their main mission to serve this population.
Right, wonderful. Yeah, and so, you know, we're so grateful that the Cancer Support Community can offer those services, especially with Los Angeles being such a large area, and, you know, more than half of our residents of LA County speak a language other than English, right, at home. So it's really important to have these services available in their language. So I really appreciate that, Sylvia, for adding that. And I'm going to start now with our next panelist, so Rhonda Smith. So Rhonda, can you speak a little bit about the California Cancer Care Equity Act and how this is going to impact access to care for constituents?
me unmute myself. So it's great to see some familiar faces that I haven't seen in a while. So thank you for the opportunity to be here with you all today. Yeah, so I guess I'd like to start by reflecting on some of my experiences working in the breast cancer realm and what I kind of knew anecdotally, but didn't have the data to actually prove it. And I'm happy that, working with the City of Hope, that there's now evidence-based information about this. And so when you look at health outcomes or cancer outcomes for the Medi-Cal population, I knew that, at least in my mind, based on my experience, that there was definitely disparities within the treatment area, when it comes to timeliness to care, what happens once there's a screening and there's a follow-up diagnostic needed. And so I believe that the whole process works differently for Medi-Cal recipients than it did for privately insured or commercially insured patients and individuals. And so thanks to the folks at City of Hope, there's evidence that does show that there's a huge significant difference in the outcomes for Medi-Cal patients versus others. And so that really informs the basis for the Cancer Care Equity Act, which specifically focuses on the Medi-Cal recipients with complex cancers and enables them to actually, get services and treatment at one of the NCI designated cancer centers in California, and then also enrollment into clinical trials, which typically does not happen in the Medi-Cal healthcare system. And so we also know that, unfortunately, oftentimes, as a Medi-Cal recipient, the standard of care is not always delivered in terms of the latest and most innovative forms of treatment for various reasons, which I won't go into. But we know that that is the case, and that is the reality for Medi-Cal recipients. And we know that with the Cancer Care Equity Act, it will address all of those issues. And ultimately, when it's passed, fingers crossed, that it will definitely enable more equity across individuals, regardless of their income or type of insurance that they have, and then ultimately improve outcomes for that specific population of patients.
Thank you, Rhonda. That is so important because I personally have gone through that. My aunt, when she was diagnosed with breast cancer, was on Medi-Cal. And of course, my first thought when I was at City of Hope was, let's bring her to City of Hope. And I had no idea of the hurdles, right? Trying to get her to come and, especially when Medi-Cal went to that managed care option, right? It made it a little bit more difficult to access care, at comprehensive cancer centers. And unfortunately, you're right. The literature shows there is a hierarchy of care. The people who go to comprehensive cancer centers have better health outcomes than people who are on Medi-Cal. And so I did see it firsthand with my aunt. And I know it was taking so long that after a month, she said, I don't want to wait anymore. I'm going to go with, whoever the Medi-Cal is going to pay for. And, she apologized and said, no, there's nothing to apologize for, And so, but I see it from a different viewpoint now, having gone through it myself. And this is I consider myself someone that knows how to navigate the system. And I couldn't navigate it for her. So I can't imagine what it's like for people who don't know how to navigate it, like people like my aunt who don't speak the language, right? And so I can't imagine how difficult it can be when I found it so frustrating.
Right, or someone who doesn't have an advocate, right, or support resource like you to walk them through it. And I know Ghecemy knows that because she's very much involved with a partner in crime, Rhonda Sandifer. So they do a lot of amazing work in terms of supporting women and helping to navigate breast cancer survivors and women diagnosed with breast cancer through that whole process. But, when we talk about equity, it really shouldn't matter, how much money you make, where you live, what your zip code is, what country you're from, what language you speak, or the type of healthcare insurance you have. But unfortunately, that is the reality of the system that we operate and live in. But, I hope that one day we will actually get there where it doesn't matter, healthcare is a right as opposed to a privilege or, what you can afford. And so we work every day to make sure that we, work on behalf of all Black Californians, including immigrants here in the state, because our population faces a lot of similarities with what Sylvia talked about in terms of the trust or mistrust of the healthcare system, stigma around mental health, even stigma around cancer, and not really talking about it very much in the community and sharing your family health history, especially if there's been several cancer diagnoses within the family. So those conversations are important to have, and we are doing our part to help make those conversations a little more comfortable, and also improve health literacy across the board when it comes to all types of healthcare conditions and diseases. So.
Thank you, Rhonda. That's wonderful. And so adding to that, what are there any other steps that the California Black Health Network is taking to close that gap in health disparities for Black Californians?
Yeah. So the primary focus of the work we do is outreach, education. We do programmatic work to actually do not direct services, but direct programmatic work to have an impact on the community. But we also get involved in policy and advocacy work. And we know, I say programs come and go. While they're great, programs come and go, but policy most often are lasting. And so if we can align, policies with programs to make sure that there's sustainability and really lasting significant change when it comes to access to care, or, expanding benefits to different types of healthcare services, that is really what is important, and where we have been historically over the past 40 years have focused our efforts and really connecting those dots.
Well, thank you so much, Rhonda. We really appreciate you, and the fact that, we have the California Black Health Network, to help in this, to uncover these health inequities and then to address them so that we can close that gap. So thank you very much. So I'm going to move on to my next panelist. So we're going to talk to Dr. Shannon Cava again. So Dr. Cava, can you tell us, in what ways are people impacted by cancer benefiting from collaborative approaches to care?
Oh, thank you, Myra. Well, for one, I would just say, case in point, the incredible group of people that we have together on this panel. It's through collaboration and through working together and through building these relationships that we know each other. I feel lucky because I know all of you. So it is very nice, like Rhonda said, to see people maybe I haven't seen in a bit. I think it's because you're broadening your reach by so much when you work with someone else and when you partner with another organization or with a system. So what we do here in Los Angeles can go so far, but if we're able to work with other organizations on shared goals, I think it just expands that. It by volumes, actually. And it improves what we're already delivering. So I would add to that, it's not just delivering the service maybe that we've been doing, but how do we modify what our service is? How do we adapt? How do we change to what the needs are of the community as we are partnering? And I think that's a strong point of growth for any organization, because I think it's maybe back to that comfort zone question earlier. It's getting out of your comfort zone, but it's hearing what the needs are and realizing that there's nothing in stone. COVID, if it taught us anything, it's to be flexible, to be resilient, and I think that comes in collaboration as well. So, but definitely making these relationships and just seeing how can we do this together is a great place to start, and it does go far.
Yeah, absolutely. And I, like you, have the honor and pleasure of knowing most of the panelists personally and professionally, and it's because of that collaborative effort, right? And it's because we can't do it all alone, and especially when we're working in a place like California, which is the largest state by population, right? And so we really need to work together to leverage each other's strengths, to leverage each other's resources, and that's when we can actually see that impact. So I really appreciate you sharing that, Dr. Cava. Now I'm gonna go. Oh, I'm sorry. Did you want to add something to that? Saw you unmute yourself, Dr. Cava.
Oh no, I'm good. I just stopped making noise, so
Well, thank you so much. Now I'm going to move on to our panelist, Dr. Ghecemy Lopez. So welcome, Dr. Ghecemy. And so I wanted to ask you, and Rhonda kind of touched on this a little bit, wanted to see, what is the importance of navigation in cancer care and having that ability to kind of navigate through the system, whether it's through treatment, diagnosis, treatment, and survivorship?
Thank you, Mayra. It's very important. I hope you can hear me. Yes, thank you. I hope that every patient deserves to have a navigator by their side. I find it very disappointing and sad. When I was actually working on my doctorate, I did some research on it, and I remember learning how technically the navigators, patient navigators, are not mandatory in the hospital system. And for us to live in the United States, where we have available so many wonderful opportunities and things in our reach, I think that it's something that we need to change. Like, it's part of the systemic change that we have to do as a society, and in healthcare particularly. Navigators help patients to go side by side during the difficult journey of cancer. I would say that it's the guide that they need in the moment of darkness, pretty much. Someone that can explain to you what is about to happen, that can go along with you step by step, and that can connect you, serve as a liaison with the resources, not only in the hospital, but also our external resources, like in this case, Cancer Support Community and all our partners, and that can help make the road a bit easier for the patient and the family members, especially caregivers. I think I'm a two-time cancer survivor myself, immigrant, and going through this journey without my family or friends nearby in the beginning, it was very challenging. So having a navigator would have really supported me throughout my journey. I think it would have made a whole lot difference. So that's why I changed careers and decided to focus on navigation. I think it was very important, especially because we are dealing with diverse communities who are in great need of culturally and linguistically sensitive information, but more than anything, that we deserve to have trauma-informed care and navigators who are also, trauma-informed, sensitive to the needs of our patients.
Thank you so much, Dr. Lopez. And I mean, I know personally how you go out of your way when you navigate patients, how you personally take on some of this. And so, they are very lucky to have you in navigating them. And I think it's also because you bring that different perspective, right? You have been through that. And so you're able to relate to them on a different level because of your experience. Is that correct?
Yes, that's correct. Like, even when you have to explain things about a chemotherapy, I lived through that. Losing your hair, I lived through that, and even just the challenges of the system. The fact that nobody in my family speaks English other than me has been difficult. However, the fact that I had a full-time employment, as well as access to a good insurance, obviously that was the privilege that not many of my patients have. And that's what motivated me, that if I had it difficult, I cannot imagine someone who had way more social determinants of health against themselves. So this is why we have to work together as a collaborative environment, because as a community, we are far beyond our institutions. We have to see these far beyond the ethnicities. We have to help all the patients, regardless of their background.
Thank you so much. And Sylvia, I see that you raised your hand. Unmute yourself, Sylvia.
Thank you. I just wanted to add to what Ghecemy said. The impact of the navigator cannot be overstated, and I think really important is the empowerment that they provide. So especially for people that are disenfranchised or marginalized, they need someone to tell them that it's okay to ask for services or demand services. They have already, especially women, been dismissed and discounted for so many reasons. And so that person, that navigator who can say, you have to advocate for yourself, that's actually been shown in the literature to be a significant factor. Dr. Patricia Gantz, who's a really well-known breast cancer researcher at my old center at UCLA, just a few years ago, published a study about how having one meeting with I think it was a nurse who was able to help the patients advocate for themselves, just one session with their doctors, significantly improved their symptoms, their outcomes, their outlook, everything, their emotional well-being, just that one session where they said, it's okay, you can advocate for yourself. Here's how you do it.
That's amazing that just one visit can do that. What are the outcomes when we have a navigator who's with them throughout the whole process, right? So, I mean, and I think that's a great opportunity, right? Because sometimes I know we focus a lot on the challenges, right? And when it comes to health equity, but then, part of the other side of that lens is we also need to focus on the opportunities and what we really need to take advantage of. And back to, what Ghecemy said, it's like right now it's not a requirement for hospitals to have this, which then goes back to what Rhonda says, that, what is a program if we don't affect policy? And so maybe making sure that this is a policy, right? So I want to remind all our attendees to please submit your questions. You have this wonderful roundtable of experts here that are available to answer your questions. I don't want to take up the whole time having them answer my questions because then this becomes, personally for me. But, I do have a participant that asked, and please feel free, anybody to kind of jump in here. But what recommendations do you have for patients to advocate in the healthcare system who do not have a navigator?
So I'll try to answer that, but I wanted to speak to something that Ghecemy said also, and Sylvia. And so, when we think about or talk about health literacy, right, we view that being on both sides of the patient-provider relationship. So yes, we can empower patients, and the work that we aspire to do really is to help them understand how to have a conversation with their healthcare provider, no matter what type or who that provider is, knowing what their patient rights are, knowing how to advocate for themselves and their loved ones, knowing that they really should be at the center of decision-making for their care, and helping them understand how to do that so that they can really be empowered and be proactive about their health and well-being. And on the other side of that, we will eventually focus on how do we improve the health literacy of providers, right? Because it is a two-way relationship, and enabling them to be more culturally competent and engage in more cultural humility. And I was on a call earlier actually talking about planning for a breast cancer event that we're having on Metastatic Breast Cancer Day. And one of the speakers is an MD MPH. And she was talking about how having the MPH degree definitely formed her perspective on dealing with patients. And she gave a great analogy about, if you see babies floating down the river, typical medicine, you want to take them out one at a time, but with a lens from an MPH degree, you want to know why the baby's in the river in the first place, right? So you really want to better understand and get to the root cause or why these things are happening. So, so that being said, I'll try to respond to the question. And what's the question again? So sorry.
It's what recommendations do you have for patients who to advocate in their healthcare when they don't have access to a navigator?
So I think with the breast cancer diagnosis in particular, you can go to trusted resources like the American Cancer Society, the Cancer Support Community. There are plenty of breast cancer organizations out there that are trusted sources of information. So really taking it up, the initiative and upon themselves to really understand what their diagnosis is. I have women who are very well educated, and I have asked them well, what is your diagnosis? And they say, I have breast cancer. And I'm like, yeah, but what type? And they're like, well, I don't know. But yeah, but you can ask the doctor that question, and that you can actually get your biopsy report and like all of your medical records so that you really clearly understand. And there are resources that can help you interpret like what is in those reports. So I think a lot of times women in the community just don't know what they don't know, and they don't know what resources are available to them. And so, we try to increase awareness and facilitate access to those resources and support services like what Ghecemy and Rhonda do and the cancer support community does. So I think that would be what I would recommend as a first step, is like really, I think we all should know whatever health condition we have. We should definitely know what it is about, what are the implications, to what degree that health condition has progressed, and what does that mean, and what are the options for treatment. So we should all be empowered to know all of that information about our healthcare situation. So hopefully that answered your question.
Thank you so much, Rhonda. Do any other of our panelists want to add to that question about what you can do to advocate when you don't have access to a navigator?
I would like to add something if possible. I think that if the person doesn't have access to one of these cancer organizations for whatever reason, because like Rhonda mentioned, it's now easier, especially after the pandemic, everybody has access via phone or FaceTime or something. And now what I usually recommend to people, especially who have more limited resources like that, it's make sure you bring somebody with you to your appointment. If you are not able to have a navigator, at least what I would always recommend, try to get either a family member or a friend or a neighbor who could be a little bit neutral, because I think that also plays a big role in the decision-making process. I have been asked to join in, and this was prior to my current position, where in the very beginning of my advocacy days, I had a patient who was bilingual actually monolingual in Spanish, and she brought along the only person that could help her was her neighbor, but she was Korean speaking. Her English was very limited. So obviously I was trying to help there because I was bilingual. But if you're going to get that type of help from a neighbor, make sure the neighbor can really relate to you the information and vice versa, because she had the best intention in the world. I have also been in appointments where they bring somebody who it's very emotional. It's even more emotional than the patient in the appointment. So if that person is crying and feeling vulnerable, it's not going to be able to take notes for you. So you might need, if you're going to invite that person, bring somebody else additional. So like 2 people, that the other person can stay on top taking notes and advocating on your behalf if you obviously don't feel like your mind is not there. So it's okay to bring somebody else.
Thank you, Dr. Lopez. Dr. Cava?
Just to add to that, because that's beautiful, and especially to be supportive, like in the moments when they're in an appointment. And we very much see at our community, sometimes even individuals connecting and helping each other with their appointments, much to what you were saying. And I'd add too that in the support groups, we often see individuals where they're really connecting, but they're learning. So it might not be to the point of the appointment, but it is that piece that Rhonda spoke to about empowerment. And there's a quote that it's an anonymous that resonated with me, and it's, I don't empower you, I recognize that you are powerful. And I see happening in our groups, people recognizing their own power because they are not alone, because they are talking to others and learning and sharing. And I think that in and of itself gives that power to be able to go forward into some of these appointments as well. So some on that preparation side, to just normalize the experience a little, to be a little socialized and not feel so alone, can help too.
Yeah, thank you, Dr. LaCava. Dr. Whitacre.
Yeah, I just want to add to that. It's so beautiful and so very important, this idea of this collective experience and having this connection with people, reminding us that we're not alone on our journey, reminding us that this person has made it and here's how, and we gather coping strategies, we gather information in that way. And oftentimes those, in particular, those support groups, if I don't have a navigator specific person, going to those groups and finding out what kind of questions are asked, because in the moment it can feel so incredibly overwhelming, just as all of my colleagues here have said previously, right, that there's emotions and we get very overwhelmed very quickly. And so just finding that space where I can write my questions down or write, what is it that I want to ask? What's important to me? What is my diagnosis? What does that look like? All of these things become so important to our ongoing healing. So I just want to add that.
Absolutely. And somebody submitted a question related to that, related to navigators. So this person said that where they work at an addiction treatment facility, that there are no navigators for that. And how would they go about advocating for one, and with whom? Anybody have any suggestions?
Can you repeat again, please?
So this person works at a treatment facility where there are no navigators, and they want to know how they can advocate so that the facility has one. And then who do they advocate with in order to get a navigator at their facility?
I know that this is a very small piece of the answer, I'm sure, but I know that there are a lot of programs that are now training promotoras de salud and community health workers to work in substance abuse. And so perhaps that's one way to go, where you have someone from the community, a peer support model. I know that doesn't mean it's that easy to go out and recruit someone, but I know that there are programs that train them. I know in Los Angeles, I believe that LA County has a program where they were training promotoras de salud, right?
Yes, they do.
You know about that, yeah.
You can contact the LA County Department of Public Health, and they probably can connect you with their team of promotoras. And I would probably suggest that if you work especially in a nonprofit or a clinic, you could apply for a grant, and that way they can provide the funds to cover for in this case, the promotora will work as a lay navigator that could assist in your clinic and get some funds to cover their stipend or their salary. And now nowadays we actually in California we have the support that medical can be built for healthcare workers like promotoras de salud. So if you are able to justify that and you have medical patients, then you could potentially pay for those assistance. So that way you can develop your own navigators, at least one or two that can help to begin with.
Yeah, thank you for introducing that, Dr. Lopez. Oh, sorry, go ahead, Rhonda.
No, I was going to add to that. So the Susan G. Komen Foundation has their health equity program is called Stand for Her, and it's their patient navigation program. So they actually have individuals who serve as patient navigators in communities. I know for the African American community, I believe for the Latino community as well. So that is one resource or access point to get connected to a patient navigator in the area. And I don't know all the locations in California, but I do know that they have several patient navigators in California, especially in Southern California.
Or even contacting organizations like Visión y Compromiso that have like hundreds of promotores and that are available in different topics, well-versed in different topics. So maybe one of the organizations can partner with them, the collaborations that we spoke about earlier.
Yeah. And I want to add, so because I am working on that, now the community health worker benefit is paid through Medicaid, right?
Right.
And so it's a covered benefit in the state of California. I think the only other state that covers it is Minnesota. I know they were the first state, because I did work on that policy analysis, and now on the provider end of it, I'm working on implementing it and how that's going to look. So that's definitely going to be, an opportunity that, all they're going to need is a recommendation from a provider, and the provider doesn't have to be a doctor only, right? It can be a physician's assistant, a nurse, a therapist. It could come from all of these people who are considered providers under Medicaid. So as long as they have a recommendation, there's no authorization required either. So you don't have to wait for an authorization to come through. As long as there's that recommendation, a CHW can provide these, what they're considered under preventive health services. So that's definitely an option. So thank you everyone for, sharing your insights.
Can I add one more thing to that? Because
Sure.
someone put a question in the chat about data. And so when we talk about maybe being able to have navigation support resources at a treatment center, right? We know that there's evidence that patient outcomes are far better if there's a navigator to support them during their journey. And so having that data and that evidence builds the case for support and adding those resources. And I think this could be a potential where there's, the connection between the program and the policy that could require cancer centers to have that and find a way for, reimbursement to happen as part of that process. So, so hopefully for the person who asked that question, that's one example where data it becomes important.
Yes, wonderful. Thank you, Rhonda. And I'm going to move on to another question that's kind of related to what we touched upon, because we did bring up support groups. Somebody asked, how can support groups aid in increasing access to care?
I can take that one. Or at least start, because I'd really like to hear from all of you. And I know Dr. Whitacre also does support groups too. In terms of access, I think part of it is in some ways a comfortable or more comfortable place to start in terms of getting support when there is something like a chronic illness or a medical diagnosis. So this might not be somebody who is familiar with mental health care, or there could be some stigma around it if we're talking about larger communities and cultures. If there's access to care, all those things would come into play. So sometimes making it accessible. We've done support groups embedded in other organizations. We've also had things that we tried and didn't work. And we've thought, okay, so maybe support group is not what needs to be here. Maybe this isn't a social event. We did a Korean speaking meet and greet with coffee and a clinician. So there was something there to just lend itself. So I think it can be a good way to dip a toe into what supportive care can feel like, to reduce some of that anxiety and stigma around mental health services. So it's very different than hanging the shingle on the door. It's more of a welcoming and really making I think a comfortable place. And then that in and of itself, and the people that will be like fellow group members, I think can really take it from there. In our groups, and you may have heard this along the day, but we call ourselves facilitators. We're all licensed mental health providers, but we don't call ourselves therapists in the room. We call ourselves facilitators because the experts are those that come together, and we are there to really just help them. So it's definitely a support group model. So I would say that can be a way to really start getting bigger access and more access to care.
Would anybody like to add about how support groups can aid, Dr. Whitacre?
Yeah, groups are such a powerful connection that we make with one another. I mean, we're social animals, and having that opportunity to just come together. I love what Dr. Cava said. It's just opening that door and allowing that little space for a conversation to start can be everything, right? I mean, that's where that seed can be planted. I run grief and loss groups here at the LA LGBT Center. I've been running grief and loss groups for some time for the state of California as well in the correction setting. And I know that, oftentimes these conversations can feel so uncomfortable, and we feel so vulnerable. And when you just open up that space and allow for just a very non-judgmental conversation to begin, just like what was previously said, sometimes that can just start it all. And then people come together and start to identify the similarities. Because I agree, I mean, the people are the experts of their own lived experience. I don't know what it's like to walk in their shoes, but I'm privileged to be just on the journey, and so just kind of framing it in that way and letting people know that they're not alone can make such a difference. So it can just start by opening the door.
Thank you. And we're happy to see that cancer support community has that door open, right? Along with the LA LGBT Center and other organizations. And before I move on to my next question, I just want to let you know that we have a comment for our panelists. Someone saying, I am so proud of all these organizations, especially to the women who dedicate their lives to these needed resources. So that's a big shout out to all of you panelists, because we know you are all of these women who are dedicating your lives to providing these resources to our most marginalized communities. But I'm going to move on to our next question, which is also related a little bit to access. So this question says, access to information and services are of course critical. Even with this access, a person may be emotionally overwhelmed, cognitive impaired from chemo, and not motivated, but in great need of support. Can you speak to this subgroup and cultural responses and differences as this would impact the patient's medical status in a multitude of ways?
I probably can take that. Well, it's actually research really has shown that the quality of life of a patient or a survivor, long-term survivor, increases when they have, you know, like this support that is in like a sensitive manner. I think that it's very important that we continue to identify opportunities as organizations or clinics or hospitals that we can continue providing and expanding the diversity of our programs. I think that unfortunately, many times, if I guess historically, we have been not specific about the heterogeneous condition of our groups. And that's why this hasn't happened. But we are in a very good time right now when everything like health equity is at the forefront of the initiatives in many places. So I am very excited about what's coming. I can't wait for Rhonda's act that she mentioned to pass and to be able to be more sympathetic to our communities, especially because I think many times we're forgetting that we are not just assisting people who are multiculturally diverse, but we're also forgetting that some of them are still immigrants, new immigrants, and they come with different ideas of what healthcare looks like. So we have to be able to explain that and tailor that, because we have to serve the newly arrived people as well as those who have been for generations in this country. So we also have to keep that in mind.
Thank you, Dr. Lopez. Would any other of our panelists like to add in terms of how, you know, being emotionally overwhelmed and cognitively impaired can kind of affect, you know, your health outcome and medical status, and what we can do to help this group?
Well, we know that, you know, to throw this out there. So there's a scientific term called psychoneuroimmunology. I don't know if you guys, so that is basically mind over matter, right? So we have, I think it's important to think about the whole person. So when we, especially when it comes to survivorship, but I think survivorship starts from the moment that you're diagnosed and not when you're done with treatment, but really understanding that the physical, mental, emotional, and spiritual aspects of one's well-being is all interconnected. And if you're not emotionally well, that can affect you physically, mentally. So it's looking at the whole person, and especially when it comes to like recovery, right? You know, having gone through that process myself, right? I suffered from chemo brain, and I was really in the thick of my consulting career at the time. And, you know, my brain was my tool, but nobody could tell me anything about what to do or, you know, give me answers. And so I struggled with that a lot, but I worked really hard to try to overcome that. But imagine if there's a woman who, or any individual who doesn't have the access to resources or know, right, you know, what to do. So it's important, you know, as great as the medical team is, you know, everybody is very specialized. The medical oncologist, you know, is very well versed in chemotherapy, and the radiology oncologist that does their thing, and the surgeon does their thing. But in terms of being able to come together as a team, that doesn't happen as often as it needs to, and really thinking about the whole person when it comes to especially cancer care, right? And dealing with, you know, a life-threatening illness like that. So.
Thank you, Rhonda. Yes, Sylvia.
Just a quick aside, and sorry to keep pulling back to navigators and promotoras on this, but I heard of a model that makes a lot of sense. So for people who are really feeling overwhelmed, Latinas contra el Cancer, in addition to the facilitator, has a navigator who calls the participants a day or two before to see how they're feeling, remind them that the session is coming up, connect with them, provide any kind of support they need to attend. And then also the same day, if they feel like that person is particularly burdened, checking in on them. And then that navigator / community health worker is also sitting in the session. And if the facilitator is not able to connect with the participant or a participant during the session, that navigator, because that person has, you know, superhuman powers, I guess, will make an extra attempt to either bring them in or connect with them or provide whatever is needed. So again, it's that sort of extra help for people that really are overburdened and need that extra support, which I thought was a really interesting model. And maybe others have used that same model, but I thought it was worth sharing.
Wonderful, thank you. Yes, Dr. Cava.
Yeah, I just wanted to add to whomever put that question out to us. It was a great and thoughtful question. And to just the piece about that chemo brain or that cognitive component after chemotherapy, Dr. Arash Asher, who's actually our next speaker, he hosts the Emerging from the Haze program at Cedars-Sinai. That is really there to be a supportive series for individuals going through that chemo brain, that fog. So if he doesn't answer it in his slide deck, I hope that attendee will be able to stay and ask that question to Dr. Asher.
Wonderful, thank you. I might just jot it down or bring it back in case, you know, they don't add it into the chat again. So I'm going to move on to our next question. And the next question is, do you think virtual care has been helpful in increasing equity?
Absolutely. It seems like in the work that we were doing at UCLA, we were able to have a lot more participants attend trainings, attend sessions. It has untold benefits and conveniences for people who wouldn't otherwise be able to be there. And I remember one of the first meetings that I attended after COVID began was one where Dr. Cava attended, and she was talking about some of the support groups that she was offering and telling us that people were able to attend from their beds, and what an incredible thing that was. So yes, absolutely.
And if I can follow, and thank you, Sylvia. I remember that conversation because I'm going to share something else from that meeting that we were at. Yes, we had people joining from the hospital. We have actual social events for families right now where sometimes the child is inpatient with one parent and the sibling is home with another parent, and they were all able to join and do an event together and an activity together online. So it does, I think, have incredible benefit. There was a bumpy start. I will say, I think we've come a long way. We were ready to start implementing some virtual programming just ahead of COVID, and we had a clinical team meeting that was virtual, but we had no idea what we were looking at, you know, we were about to encounter with COVID. One of the items that I do remember talking to Sylvia about was early on in Zoom, there were a lot of individuals who wanted to join by phone, or they didn't have the video capability or the bandwidth and internet. And we came up against obstacles and then found a solution, and we'd come up against another obstacle and find a solution. One being the outgoing message. If you called in from anywhere in the United States, it was English only to be able to join a group. So we could set up everything, translate everything, and then get there. And it's like, wait, so multiple calls to Zoom. But I think you recognize had the ability to recognize and collaborate and talk with others that were going through it. And I think that made it easier. But definitely today, I think we have a lot of individuals that are so happy with virtual, they don't plan to return to in-person services. So we can have this is now a sixth pillar, I keep calling it, because it's here and it's incredible. And just like this, I think for us as professionals, there's been such a value in the virtual component too. But there was some baby steps into it and some learning, some obstacles.
Yeah, for all of us, right? I mean, Zoom came into our language. That's something we didn't think about Zooming and, going on Zoom. And, I think I've never said you're on mute more in my life than I have in the last 2 years. But yes, and I think we're going to stay in that hybrid mode. A lot of us, whether it's working, right, even for work, that remote hybrid, schedule, or just being able to attend events and being able to reach larger audiences, right? We can host this event in Los Angeles that now can be shared nationwide. And so people can attend that way, or as Sylvia mentioned, or people with disabilities who couldn't otherwise, or people who have transportation barriers, and now the only thing is that we need to kind of work now on the digital divide, right? Like people who don't have access and, don't have internet. And, luckily there's some, programs and services at the state and federal level that can help with that. Or people in rural areas, right, where the network and they don't have the cell towers or, the internet that we're used to. But like you said, Shannon, little by little and kind of dealing with all those hiccups as they come. So I'm going to move on to our next question. And this kind of refers back to something you said, Rhonda, but if you want to take it, or anybody else, the person's asking any additional thoughts about how data come into play when making decisions in regards to equity. You're muted, Rhonda.
Trying to, okay.
There we go, we're back.
Yeah, there we go, yeah. So I think, we have to have evidence to know that disparities or differences in outcomes for various populations of people exist in the first place. And so we can say it anecdotally, but we have evidence to prove. And unfortunately, when we look at the African-American community, whether it's, maternal health and infant mortality, or cancer outcomes, or, chronic diseases, or rare diseases, unfortunately, there's a huge disparity. And I know I was just recently looking at some diabetes information, and, it was always a gap in terms of diabetes death between African Americans in California and, most other populations. But COVID really, messed up everything for everybody, in terms of, mental health, right? We see when now we're talking about mental health, we know that, in our case, even before COVID, there was a 45% increase in the Black teen suicide rate. And we've seen more, even in the media, right? More well-known people or their children or individuals, like I think it was Miss USA. And then Regina King, who's an actress, her son committed suicide. In my personal network, I know someone's 13-year-old granddaughter, tried to commit suicide. Fortunately, she was unsuccessful. So, there's a lot going on. So not knowing that information or having that data, right, we wouldn't know that there's this issue to begin with, or there is a significant increase, and oftentimes a correlation between what we all experienced for the 2 years, or at least in 2020, because of COVID, and the impact that it's had on all of us and on mental health and well-being, and especially the youth, when we talk about being isolated and the lack of being able to socialize with their peers, and cyberbullying and all of that really comes into play. So we need that data and information to know how to act and come up with solutions to really drive change and address those issues.
Yeah, I love that point. That data brings us from awareness to action, right? I mean, the data is what builds the awareness. And so I definitely agree with you, Rhonda. And I think one of the challenges is, just collecting that data so that we can uncover these inequities, right? So that, we don't know what we don't know. And so we can't address them if we don't know what's happening. And I think one of the biggest things in data that we can do is work on having disaggregated data, right? Because we have data in aggregate. For example, Asians are all lumped together, Latinos are all lumped together, as an ethnicity, but we're not really a race, right? We come in all races. But there can be specific inequities that happen within those communities. For example, and it can be not just by race, but also by geographic location, country of origin. And so, for example, I know when we were looking at cervical cancer screening rates, it looked like the Asian population was doing fine. They're great. We don't need to do a cervical cancer campaign. But then if you dig deeper into the data and you have more disaggregated data, we could realize that Vietnamese women were under screening, right? They needed Pap testing. And so we were able to develop a campaign specifically for Vietnamese women between the ages of 25 and 39, because those are the women that we were seeing that weren't getting cervical cancer screening. But if we didn't collect that data to know, because we lump, Asian and sometimes, Asian and Pacific Islanders sometimes get lumped together, right? And we know that everybody has different outcomes. And I know we see that too, in LA, if we pull out, different communities. So I think one of the biggest pushes too is, making sure that we are able to collect that disaggregated data so we can get it to the granular level and uncover some of these inequities that could be hidden because we lump everybody together in one group. But does anybody have any other suggestions about data and how it comes into play when making decisions regarding equity?
I think one other thing, because we're doing research to learn about, what potential policies we could focus on. And I think for us and the work that we do, it's important to focus on policies that address issues at the system level and that infrastructure of care, right, to get to the root cause of the problem. And we know that one of the things that happens, this is kind of data driven, is that in algorithms that are used within the healthcare system to make decisions about patient care has bias in it. So it's more about health inequity, right, than health equity. And so it's important to really, I think, call that out and be aware of that and understand that needs to change, right? Because there's fallacies in those algorithms because of the assumptions that have been made historically about certain populations of patients. And so those type of decisions impact patient care and also outcomes. So, if we can do our part to help drive change around that, to advance health equity and dismantle some of the root causes of inequities to begin with. And, those are things that we can do and have the data, right, to address those issues and make those changes.
Thank you, Rhonda. Sylvia?
I just wanted to say briefly, because I was working at a research center at UCLA, data is so critically important. And really, we talk about cancer survivorship, but it's really a critical area of emerging research. I mean, it's still fairly new. We don't have a full picture yet, but we know how important it is to include diverse groups like Latinos and Blacks in cancer survivorship. And we need to do a better job. And we can't do a better job unless we have a really strong representation among academics, among, hospital staff. I think the percentage of hospital leadership right now that is Latino is like 2% in the United States. It's really dismal. And so that has to change. The pipelines really have to change because we have to collect data at every level, at every single level, in hospitals and academic institutions, at the clinical level. And it's not going to happen unless those people make it a priority to collect it.
Thank you, Sylvia. And that's a perfect segue for our latest question that's asking, how can we help patients feel more comfortable providing demographics data? And, I'm going to actually ask you, Dr. Whitacre, because I know one of the things that we have been working on is collecting SOGI data, right? Well, sexual orientation and gender identity data. And some people think that one of the unintended consequences is that that data is going to be out there for people that they might not be comfortable sharing. So I was wondering if maybe you, Dr. Whitacre, and any of the other panelists might have, some suggestions on how we can help people be more comfortable providing that data.
Yeah, that's a really great question. And I wish there was a very specific answer to that. I think that, when it comes to that, when it comes to asking these questions that people feel very vulnerable responding to, right? Being able to just provide that safe space, maybe even walking people through the intention or the purpose, if that's something that's possible, but allowing them the space to know that what is being asked for is generally for the greater good, and I think if we can just remove the judgment just from the way in which we process or the way in which we ask the questions, that becomes such an important thing. I know as a clinician here, this is a big piece of what I do, and asking those really uncomfortable questions, and just finding a way to change the language, the manner in which we approach it. So much of it is just around our word choice and being mindful of that, being mindful when we're gathering data that could potentially be problematic for people, and that's why so many of our numbers are so incredibly they're low, right? And when we look at suicide, when we look at so many different areas, oftentimes our numbers are not really reflecting the real challenges because of that, because people don't feel safe, reporting a intimate partner violence or whatever that might be. So when it comes to gathering that data, just really finding a way to be mindful of the language that we're using when we're asking the questions. I think for me, that's what's been most helpful.
Thank you, Dr. Whitacre. Do any other of our panelists have a suggestion on how we can help people feel more comfortable when we're collecting this data?
I think I can answer that. I think that it all comes down to transparency and ensuring that the person understands why we're collecting specific data, what the purpose of that is, how that may impact them as individuals, but also as part of a community of, especially a vulnerable community. And that has been also my experience in the work that I do, trying to protect the integrity and the privacy of my patients, especially if they have either undocumented issues or maybe they may be incarcerated, or they might have other issues that could jeopardize their freedom. And I think that's so important for us to keep that in mind. And like I said, making sure that either myself or the team that is working with the population, everybody has to be trauma informed, because I think that's what really makes the difference, that we are able to be empathetic with their situation and not to assume that it's going to be safe. I remember during there was an occasion where there was a police officer that passed away in the hospital, and I was outside like 2 blocks away from there, and I saw a couple of my patients with their family members, and they were like trying to walk as fast as possible the opposite direction. And I say, what's going on? And I said, I think there is a raid at the hospital. And I was like, what are you talking about? And I knew that there was a police officer that had passed away, but it was like that fear from people, like, what if they ask me for more information than they need to know? And even if they have a medical card, they might be asked other questions. So we have to be very careful on how we present information like that.
Thank you, Dr. Lopez. I'm going to ask one question here that some people might have. And so I know we've been using the term health disparities and the term health inequities. So someone is asking, how are health inequities different from health disparities? Anybody want to add to that? It's a good question because we do use them a lot. I can give it a shot if none of the panelists want it. So like for me, oh, go ahead, Rhonda.
Well, I was going to say, so when we look at health disparities, right, we look at the incidence of disease, right, and the gaps or, you know, differences in that, you know, for one race or ethnic group compared to others, or, you know, health outcomes or, you know, outcomes related to that. But when we talk about, I would say, yeah, so inequities and then there's equity, right? So when we look at equity, that means that everybody has access to what they need. It's not like everybody gets the same thing. It's really, it's kind of like personalized medicine, right? You're looking at that individual and you're giving that individual the level of care and the quality care that that individual needs for whatever health condition or challenge they're dealing with. I mean, inequities, I kind of view really more stemming from the infrastructure and the system itself, right? That creates inequities, whether it stems from implicit bias or, you know, what I talked about before, you know, the algorithms or how patients are perceived, or, you know, the myths about certain patients that drive decisions, or what gets in the soap notes for patients if sometimes someone, at least the assumption is made that they're not compliant with their medication. But it could be, you know, lots of reasons why that person didn't take their medication. It could be because they couldn't afford it, or they had to, you know, decide between their medication or paying their electricity bill or something else. But, you know, I often say health happens outside of the four walls of any health center or any clinic. And so everybody, you know's life influences what happens when they show up, right, in an exam room. And so those are the inequities, right? And those, what happens when that encounter takes place. And so I think looking at it, you know, in those three ways, I think is hopefully a way to answer that question.
That's wonderful, Rhonda. You said it much better than I ever could, because, you know, my basic explanation to people is that health disparities focus, like you said, on health outcomes and disease burden, right? When they're disparate, when different groups are affected differently, whether, you know, we use the term mortality and morbidity, right? But for me, health inequities are usually the cause of those disparities, right? Because it's things, you know, in these, the access to care, in language, and like you were saying, the implicit bias or the racism. You know, I had a doctor tell me a story when he was working at a federally qualified health center in Fresno, and he was saying that they had a 40% no-show rate. And so he asked the staff, why do we have such a high no-show rate? And they said, well, you know, these people just don't care about their health, right? And he's like, well, that's not right. And so he dug deeper and he's like, what do you mean, you know, people don't care about the health? And nobody thought to think that a lot of these people, this was one of the federally qualified health centers that was kind of far away for a lot of people. People had to take 3 buses, had to take the day off from work, had to find childcare, you know, or if they forgot to bring their medications because they were so worried about everything else, right, to get to the appointment. So it wasn't that they didn't care about their health, right? It's that there was all these other things, all these inequities, you know, that were getting, you know, becoming barriers for them to make their appointment. And so thank you, Shannon, you know, for sharing, you know, a link about Robert Wood Johnson and, you know, what are some of those differences with health equity. So I don't know, Shannon, if you want to speak to that link that they'll be sharing in the chat.
Yes, so I was going to say Robert Wood Johnson Foundation is an incredible source for information about health equity. And so I think they're going to be able to put that in the chat so you can all access this. But there's some wonderful summaries and manuals, and it really, really goes down, there it is in the chat, to all the definitions. This is more specific to the health equity, but it does also talk about the disparities component. I even saw the definition or a partial definition in Dr. Jennifer Kelly's talk. So it's a great resource for anyone that's looking to get some more detail about health equity. Just to add, Rhonda, I really thank you for your answer, because I think, and you're brave for jumping in when we all looked so quiet there. Thank you.
No, and I want to thank all of our panelists. So thank you so much, Dr. Caryn Whitacre. Thank you so much, Sylvia Lopez, Rhonda Smith, Dr. Shannon, Cava, and Dr. Ghecemy Lopez. We really appreciate you spending your lunchtime with us and your afternoon with us to share your expertise and all the wonderful ideas that you have of how to reduce, these health inequities and how we can address, the needs of some of our most vulnerable and marginalized communities. Now I'd like to introduce our next speaker. Dr. Arash Asher has served as the Director of Cancer Survivorship and Rehabilitation at Cedars-Sinai since 2008. He has a special interest in the physical and rehabilitative needs of cancer survivors who continue to experience the effects of their cancer or its treatment. Dr. Asher has led the development of several unique cancer survivorship programs with his colleagues, including Emerging from the Haze, Grace, and others, with the goal of optimizing physical, psychological, and spiritual resilience for patients with cancer. Dr. Asher completed a cancer rehabilitation fellowship at MD Anderson Cancer Center in Houston, Texas. Please welcome Dr. Asher.
Thank you so much, Myra. I very much appreciate the introduction. I appreciate the opportunity to be with you. Even I wish I could be doing this in person, but I'm glad we have the technology to allow us to connect virtually. So this is one of my favorite topics in thinking about how we can try to think outside the box in creating wellness and survivorship programs. So we entitled this presentation, Creative Strategies for Building Inclusive and Whole Person Survivorship Care. By way of introduction, just very briefly, I want to highlight what I imagine are some of my goals in my remarks. So number one, thinking about how really, even though I'm not a psychologist, and I often confess that at the beginning, I do believe that a lot of the distress that our survivors experience, at least in part, stems from psychological distress. I'm going to go over some of the various etiologies implicated in cancer-related cognitive impairment, of course, commonly known as chemo brain, and thinking about the role of social determinants of health for one of many common survivorship concerns, but I'm going to highlight cancer fatigue as kind of an example. And I'm going to spend a fair amount of time thinking about how the way we live our lives and our lifestyle, how that can improve many of the symptoms that survivors might experience. Okay, so by way of introduction, I am fortunate to be part of a much larger team. We call this the Patient and Family Support Program at Cedars-Sinai Cancer. Dr. Irwin is our medical director. But I'm going to really focus in on this arena here. Again, some of the things that we've worked on our team through the wellness, resilience, and survivorship facet for this larger program. And many of you may be aware that one of the landmark publications that came out around 2007 was from the Institute of Medicine, from cancer patient to cancer survivor, because at the time, there was finally increased recognition that when one is done with surgery, chemo, and radiation, for many of us, the existential and psychological and physical issues really come to the forefront when you finish active treatment and you're trying to integrate back to your roles in society. And so this book really highlighted the myriad of issues that one might face, from physical issues like pain and neuropathy and musculoskeletal issues and fatigue, to psychological and psychosocial issues. Of course, I'm not going to go through all of these, but I'm going to try to highlight some of our programs that were meant to address some of these concerns. And I just want to share, I guess, my biases, right? I think we all have biases, but these are, I guess, the fundamental ideas, quite simply put, that I think has really helped guide me over the years. So number one, I think we have a really fundamental job in as healthcare providers, which is, number one, we should either be doing things to help our patients live longer, or to live a better life or have a better quality of life. And I mention this because it seems obvious, but a lot of times we still may be doing things in healthcare just for the sake of doing things that may not necessarily be helping our patients live longer or better. And I think it's really important to challenge ourselves to make sure that we are following one of these two ideas. And the hope is that we really have both, that things that will help us live better will help us live longer and vice versa. My second idea was that I love yoga programs. We have a yoga program. The Cancer Supported Community Programs has great yoga programs and mindfulness programs. So I think they're wonderful. The evidence behind them is irrefutable at this point for a number of outcomes, but I don't think they're necessarily for everyone. And so I think it's worth broadening the menu of options that are made available to our patients. Whenever feasible, I think it's important to straddle a research question so that we can improve the science. And another basic idea is the following, that the types of things that we think about on a consistent basis and the kinds of behaviors we engage in, the disciplined actions that we take on a day-to-day basis really will shape our health in the long run. And that idea was really echoed in a really beautiful quote I want to, again, start with, and this is from Wilfred Peterson. And I think this really speaks to the idea of neuroplasticity, which is so important to many of the issues that we're going to be confronting in cancer survivorship. So this is what Wilfred Peterson said. As a single footstep will not make a path on the earth, so a single thought will not make a pathway in the mind. To make a deep physical path, we must walk and walk again. To make a deep mental path, we must think again and again the kind of thoughts we wish to have dominate our lives. And I think that really speaks to the importance of, again, the kind of programs that we try to offer, which is not just meant to treat a physical symptom, but really change how we are engaging with life and the kinds of behaviors and thoughts that we're bringing to this space in cancer survivorship. So I'd like to start the story with thinking about cancer fatigue and the role of exercise in medicine. And as many of you, I imagine, are aware, fatigue in many studies is felt to be the most common and for some the most distressing of side effects of treatment. And if you look at, for example, breast cancer fatigue, it seems that like a third or so of our survivors continue to struggle with fatigue months or years even after the treatment has ended. But there's a lot of variability. And that's where I think some of the research that we've been able to do with Julie Bauer, ECLA, has really helped give us some more insights on why is it that some people bounce back, but some people struggle with fatigue for these protracted periods of time, even when their treatment is ended. And for Dr. Bauer and her team, one of the first insights was a small study they did with breast cancer survivors who had fatigue and those that did not have fatigue. And what they found, and this was, again, a small study, but what they noticed is that the group that had persistent levels of fatigue, it turned out that when you looked into their past, into their childhood, they had a much higher likelihood of undergoing emotional abuse, physical abuse, sexual abuse, unstable homes, conflict, parental divorce, whether it was perceived or not. If they perceived these adversities to be real, it seemed like they had a higher likelihood of having much higher levels of fatigue. So again, giving a clue that what might be happening to us before, right before we ever had our breast cancer or cancer experience, may be impacting how we are going through this. And so the theory was that somehow that adversity, let's say in our childhood or in our teenage years or early adulthood years, somehow primed our immune system such that when you go through surgery, chemo, radiation, for example, that there's a magnified inflammatory response that may perpetuate certain symptoms like fatigue even after the treatment is gone. At least that was the theory. And that was really one of the underpinnings of this large study that we participated in with Dr. Bauer. So one of the things we looked at is, okay, we know that people who have fatigue at the very beginning, so before their chemo and radiation starts, seems to be a predictor for who's likely to have more fatigue afterwards. One basic question is, okay, well, who are the people that are more likely to have fatigue before chemo radiation? And there were a few common themes. And number one, if you're younger age, again, lower socioeconomic status, again, reflecting to our upbringing, seemed to be a risk factor. A history of, again, depression or a childhood maltreatment, again, earlier in life. And again, this is all important because if we believe that pretreatment fatigue is the strongest predictor, or at least one of the strongest predictors, it's important for us to pay attention, right? Because if we could identify these patients earlier on, we can intervene. So the next part of the study is we actually followed these patients throughout their treatment course, right? To see, you know, what kind of patterns emerge for fatigue, at least among people with breast cancer. And one of the, and I don't want to spend too much time on this, but one of the things you'll notice is that there are a myriad of patterns. And one of the reassuring features of this study was that for most individuals, you either started low and ended low, this is the stable low group, or maybe you started high because you had a lot of distress and fatigue after getting the diagnosis, but then things improved, or maybe it went up with chemo and radiation, it comes back down. So that was reassuring, but there were a couple groups that stayed high or went high over time, the increasing group or the so-called stable high group. And again, it was important to try to figure out what was it about this subgroup so we can try to help these people. And it came down to a couple of findings from the study. Number one, the stable high group was much more likely to have depression prior to their diagnosis. And almost everyone, 97%, had a significant sleep disturbance. So having a history of depression and a sleep disturbance may really set the stage, right? And may really prime us for having more persistent levels of fatigue. And so the conclusions was that we used to think a long time ago that, you know, maybe chemotherapy A or certain chemotherapy drugs may make you more likely, and we weren't able to differentiate that. So that was one important conclusion. That fatigue levels truly are variable, and thankfully many people do well, but if we could identify the people that are more likely to struggle, including this idea that if you have fatigue before your treatment starts, there's an 80% chance that it won't recover within 18 months after the treatment has ended. And rather than waiting months or years to finally attend to these folks, I think one of the lessons from this study is we want to reach out to these folks earlier, especially if they've had depression, distress, sleep disturbances prior to their diagnosis. So if we do identify these folks, then the question is, well, how can you try to support them? And I also believe, and this evidence is shown, and this is from the American College of Sports Medicine. This is, I think, a really lovely infographic on the value of exercise for including having strong levels of evidence for cancer-related fatigue. And it kind of breaks down, I'm not going to go through the details on how much aerobic exercise, how much resistance, how much of the combination ideally do you want to get to really optimally manage fatigue. And it goes down and offers suggestions for anxiety and depression, sleep, etc. But exercise, we know, is helpful. The question is also why. And there was a nice study from a few years ago that kind of went through all the myriad of mechanisms that attempted to maybe explain why exercise can reduce fatigue. And I'm not going to go through all the molecular pathways. A lot of them had to do with basically inflammatory compounds that are reduced with exercise. But since I know I'm speaking to many therapists, psychologists, social workers in the group, I really want to highlight one facet of the mechanisms discussed in the study, which I highlight up here in red, which is this idea of self-efficacy, right? So exercise improves self-efficacy. And again, I know I'm speaking to a group of therapists, so you know what self-efficacy means much more than I do, but just to get us all on the same grounding, right? Self-efficacy is this idea that we believe we can achieve our intended results, right? And we know that self-efficacy is associated with improved resilience and improved well-being. And what was interesting to me, what we've seen with our own exercise program here at Cedars-Sinai, is while there are many methods by which one can improve self-efficacy, I now know, and the evidence has shown, that exercise can meaningfully improve self-efficacy. And there's basically 4 mechanisms by this. Number one, you're having mastery of an experience. And so our patients come in and they could maybe do 5 minutes on the bike. And if they could do 20 by the end of the program, they've mastered a new experience. If they can do 5 push-ups and end with 25, they've mastered an experience. There's social modeling, right? So you'll see other participants in our wellness gym, and so if you kind of say that Mary can do this, then that may improve our sense of self-efficacy. And social persuasion, this is the job of the trainers and the exercise physiologists, where you're being cajoled to kind of push yourself and improve your fitness level. And of course, the endorphins that are produced, right? The psychological response from exercising. So exercise, I believe now, is just one example of how we can gain self-efficacy. And it seems to be an important mechanism by which exercise improves cancer-related fatigue. So the bottom line, all survivors should be counseled regarding the benefits of exercise, and it seems that we should aim for at least 150 minutes of moderate aerobic exercise. This amount is not only associated with improved fatigue, but even all-cause mortality for a number of cancer types, including breast, colon, and prostate cancer. This is echoed by virtually every major national organization. And despite all of these benefits, the challenge is that when you look at national studies, women decrease their activity by 2 hours a week after a diagnosis. If you look at women treated for breast cancer, 3 years after the treatment is ended, it's as if they have aged 20 to 30 years in terms of their cardiorespiratory fitness. And again, this is important because exercise can potentially reverse or mitigate this. And one of the reasons I take the opportunity to talk about this in every venue that I can is that studies show that 10, 20, 30%, this study was 21% of survivors recall having any discussion about the benefits of exercise with their provider. And so I don't think this is the role of just the oncologist or just the surgeon or just the rehab doctor. I think anybody that works with cancer survivors has an opportunity to at least give some basic counseling on the value of exercise in cancer survivorship and well-being. So one of the programs we developed is our Cancer Exercise Recovery Program, which is a 3-month intervention where we really individualize and tailor this in terms of the type of exercise, the intensity, the duration, and we have a little gym, and so we kind of run this program in our wellness gym. But one of the things that has not been looked at in the cancer arena is the environment, right? So we said, for example, 150 minutes of aerobic exercise we know seems to be helpful, but where we do the exercise and whether it's like a busy urban area, is it on Wilshire Boulevard or La Cienega near Cedars, or is it in a gym, or is it in a green space? Does that make a difference? And so we are in the midst of a pilot study to try to at least gather some preliminary data to see if it's feasible to convince our breast cancer survivors to come to a nature preserve and do a 3-month moderate intensity walking program. And we're really looking at not only how this impacts our well-being with patient-reported outcomes in terms of anxiety and depression and fatigue and distress, but also biologically, how is this impacting us, right? How does this change things like DNA methylation, which is implicated in biologic aging? How does this change our inflammatory markers, which we know is important for cancer survivorship and a number of important outcomes? So the hope of doing all this is once we finish this pilot study, is the next thing we hope to do is put this to the test, right? Create a randomized clinical trial where we keep all the variables the same. So you're going to do the same amount, the same duration, the same frequency, the same intensity of exercise. The only thing that would change is you'll be in either one of two spots. You'll be in a green nature preserve, or you'll be, let's say, for example, in a gym. Will it make any difference? Is it just exercise, or is there something possibly advantageous about being surrounded with trees or in nature in the sunlight? And we'll see. We'll see. Obviously, we don't have the answer quite yet. Okay, so I'm going to shift gears a little bit. The next topic I'd like to talk about is another common and important one that I contend with on an almost daily, weekly basis in our clinic, which is so-called chemo brain. And I'll explain why I have this in quotes in a second. And I imagine, of course, if you work with our cancer survivors, you'll see this. People describe their short-term memory problems. It's harder to concentrate, to attend. There's a word on the tip of your tongue and you just can't get that word out as easily. It's harder to multitask. It feels like our brains are working just a little bit more slowly than before. And again, for some people, this can be really distressing. The reason why many will argue that we should redefine chemo brain is this idea that there's no single symptom, one that defines this. And there are many people who never even had chemotherapy, right? They may have just had surgery and radiation, or maybe surgery, radiation, and hormonal treatment with like things like tamoxifen or Arimidex, or with prostate cancer, testosterone blocking drugs, and still experience those symptoms that we talked about. So the medical term that's favored now is called cancer-related cognitive impairment. And whatever you call it, at the end of the day, we have to strategize ways of trying to improve this symptom. And unfortunately, we do not have any great evidence for any drug, right? So there's been a number of medications like methylphenidate or Ritalin, modafinil, ginkgo biloba, and a few others that have been at least studied in various sample sizes. And there is no good evidence that a drug in and of itself will solve the myriad of issues that we were describing. So if you look at the NCCN, right, one of the major oncology guidelines, they'll have a busy kind of guideline telling you all the different things that we should try to do, such as, let's say like teach enhanced organizational strategies, or provide information about stress management, and consider some mindfulness training, and on and on and on. And the point I always make is, if you're a busy clinician, it's almost impossible to kind of go through all this in a clinical visit. And so what can we do to try to package this and other ideas that can improve your cognition in a way that is digestible to our patients? And so we developed what we call like a roadmap to brain health and wellness, where we kind of fleshed out what we thought were important topics like mindfulness and stress management, and thinking about all these lifestyle factors that seem to be implicated in cognitive performance, and some of the cognitive strategies that are important that our neuropsychology colleagues really have been taking the lead on. And we created our own curriculum in the program we call Emerging from the Haze. And this is now a 10-session program where we package all these different strategies. Usually sessions are about an hour, maybe an hour and a half. And our patients or participants are given kind of homework assignments to reinforce some of the key ideas and strategies. And so we did put the program through a clinical trial a couple of years ago, where we compared those who went through the program in blue and those who were in the waitlist control in red. And basically with the FACOG, this is an assessment tool that measures chemo brain type symptoms. The higher the score, the better quality of life. And thankfully, we were able to show that those who went through the program improved and seemed to have maintenance compared to the control group in red. And so that was nice. And we, when we did this study originally, we had people come to our conference room, and we're doing this program in groups of 10 or so in person. And then, of course, March 2020 came, and of course, all group programs came to a halt. And so we kind of pivoted, like you all have, and tried delivering the program in a virtual context. And I'm not going to read you this whole poster that we presented because it's too busy a slide, but just to highlight the key points, we found that, at least in this pilot study, that even a virtual delivery, so we still had 10, 15 people in the group, but they were all in a Zoom platform like we are now. It was feasible and acceptable, and we were able to show that there were improvements in kind of those patient-reported outcomes that are important for chemo brain type symptoms. But there was another important facet that we learned, that both from our original study and this study, that feeling lonely seems to be another important predictor. And I think especially as we're talking about social determinants of health today, I just want to highlight this facet because it seems to be in our work, and I'm not highlighting all the studies that we did in this space, that loneliness at least seems to be associated with higher cognitive symptoms, probably because of the stress and distress response that's associated. And so encouraging our patients to feel connected and reminding them that they are not alone. And I think that's what a group type program may offer, reminding them that they're not the only ones, right? That they could be part of a tribe and a community that's learning how to navigate through this together. That may be as important a part of the recovery as any. So again, we did this group, whether it's in person or virtually, groups of 10, maybe 15, 12 or so. And then when you think about the number of cancer survivors we have across the country, right? I think it's currently estimated around 17 million. And if we believe the statistic that maybe a third of them struggle with some kind of chemo brain type symptoms months or sometimes years after the treatment has ended, there is no way, right? There's no way we can touch that many people by doing this group 10 to 15 people at a time. So we were challenged to think a little bit more broadly and think about, how do we effectively disseminate these kind of interventions for a common concern, such as, cancer-related cognitive impairment. And so one of the ideas that we were and this is not something I ever thought I would get involved with, but that we kind of came across was, creating a standardized video product, right? And this is what, this picture was meant to show, that we were in this room, my colleague, Dr. Jeffrey Wertheimer, our lead neuropsychologist, who co-facilitates this with me. We were in this room for, I think, 3 days, all day and all night, just recording the content. And we packaged it to kind of make it uniform and standardized, so then it could be distributed, in different sites across the country. And that's basically the study that we are towards the end of right now, where we're enrolling patients with different types of solid tumors, Hodgkin's or non-Hodgkin's lymphoma. They've completed their chemo at least 6 months ago, and they're going to get randomized into one or two groups. Either you watch the live group that Dr. Wertheimer and I are doing, or a pre-recorded version that some other facilitator at a local institution, whether it's a social worker or a therapist or a speech therapist, is still facilitating, but the content is still all standardized through the video or with its control. So we're still recruiting for this study. Hopefully we're going to finish in early 2023. And again, I hope that if this is successful and our interim analysis has suggested that, our next goal is then to translate this into Spanish, right? We're going to dub this program into Spanish because we know, to the best of our knowledge, there is no standardized intervention at all for our cancer survivors who are primarily Spanish speaking. And so that is another important opportunity that we're trying to get support for creating this new product, hopefully in early 2023. And I would argue the other group that often does not have access to this kind of care is our rural population, right? So I'm working with Dr. Jamie Myers in University of Kansas. There are many of their patients that live 50 miles, 100 miles from a cancer center. They can't come to these in-person groups. So again, seeing how we can make these programs more accessible to people who live in more rural communities is another important goal for this kind of study. Okay, and I'm going to shift gears, I think, for probably the last topic that I'll have time for. And this is a program I worked on with Dr. Wertheimer after we kind of had the HAZE program rolled out. And I should say, a lot of these programs, the reason we worked on them was out of a need, right? These were patients I was seeing in clinic, and we were looking for kind of other strategies to try to support them. And so the GRACE program, in essence, was meant to address the huge issue of existential and spiritual suffering that many of our patients experience, right? Whether it's any of these facets that you see here, being preoccupied with the past or future, feeling disconnected, feeling like we want to be in control, but this sense that all our control has been stripped away from us, or this existential vacuum that some patients experience. And so as we were thinking about how to kind of frame this program, there were three fundamental questions that at least preoccupied my mind in terms of working through the content, which were, number one, what does it really mean to be healthy? And I know this seems far too simplistic, but I think what happens to many of our patients is our definition of health is really determined by what your CT scan report shows, what your tumor marker reports are they going up or are they going down, what your blood test is, what your medical report is, right? If the CT scan is good, I'll feel healthy. And if it shows something else, I won't feel healthy. And I think if we're really going to try to optimize well-being in a holistic way, we need to think about health in a larger way. What does it really mean to be resilient? And what does it really mean to be fulfilled? And as a physician, I apologize, the ambulance driving by. As a physician, I prescribe antidepressants, I prescribe anxiolytics. I think they play a very important role for a number of our patients, but I do not believe any longer that any medication in and of itself will answer these fundamental questions about living and therefore suffering, which almost invariably exists at some point in our lives. So I personally was inspired by Dr. Viktor Frankl. I imagine many of you are familiar with him. He wrote a very important book called Man's Search for Meaning. He was a Holocaust survivor and a psychiatrist that between the years of 42 and 45 was imprisoned in 4 camps, including Auschwitz. He lost virtually everyone that was important to him, including his pregnant wife. And he suffered. I mean, I think that part is clear. He clearly did suffer. But he observed as an observant psychiatrist that while suffering was omnipresent in the concentration camps, he kind of noticed that, some people seem to survive camp life better than others. And what he noticed is that those people that had a sense of meaning, a purpose, some hope, something to live for, seemed to survive the horrors of the camps with some resilience more than others. And his argument was that if you could find a sense of meaning and purpose in any of these 3 domains, and through your work, doing something significant through acts of love or acts of caring for another person, or through cultivating a sense of courage, particularly during difficult times. That any one or a combination of these ideas was really critical to living and trying to rise above the challenges that may occur when we're really going through significant challenge and significant suffering. One of the other questions he beckoned his readers to consider is to try to ask ourselves this question: what does life expect from me, rather than what, you know, the reality is most of us do, is what do I expect from life? And of course, there's just a subtle shift in the sequencing of words here, but I think you'd agree that the implications of these two different questions couldn't be greater, right? What does life expect from me, rather than what do I expect from life? And the first question, of course, brings up a lot of responsibility, right? And that's what he talks about often, is our responsibility in how we're going to respond and manage the situation that we have in hand, rather than what do I expect from life, which is, maybe more kind of pleasure seeking and maybe a more hedonistic perspective. And I think what most of us, including myself, probably grew up expecting with our upbringings. And so I remember reading this in Frankl's book a number of times, and then I came across this really fascinating study, and maybe I could just go through this very briefly. So this was a study looking at two groups of individuals. It was one group that was felt to be strongly hedonistic, and you all know what that is, right? Somebody that's primarily more pleasure-oriented, right? So and so maybe, if you had a cocktail party, this is the person that is there for the wine and the music and the nice lights and nice kind of ambiance and whatnot. And versus a eudaimonic outlook, which, if you're not familiar with that term, is more kind of oriented to this idea of virtue or service or community and doing meaningful things. And so what they did in this study, very simply, is they took a group of adults who were all happy. So on these kind of patient-reported outcomes, they reported high levels of well-being, but you were either very strongly hedonistic or strongly eudaimonic. And then what they did was they compared their inner biology. So they had blood samples, and I'll walk you through this. This is where I think things got really, really interesting. What they found, and I'm going to focus on part B for the sake of time, was the hedonistic group had higher levels of pro-inflammatory cytokines, right, which is associated with more of our chronic health problems. And they had lower levels of antibodies, which we all know is important for our immune system and how we ward off infections and whatnot. And it was basically the reverse in the eudaimonic group. They had lower levels of inflammatory cytokines, and you could see markedly higher levels of antibodies. And so when I saw this study, I couldn't help but think about, again, Frankl, right? And Frankl said, stop asking yourself, what do I expect from life? And try to ask yourself, what does life expect from me? And his argument was, remember, he observed many, many years ago that the people that had a sense of meaning and purpose seemed to live more in this what does life expect from me viewpoint. And he argued that they somehow seemed to survive life camp better. They were less vulnerable to dying from, let's say, infectious illnesses that were rampant in the concentration camps. And I couldn't help but think that, again, maybe this change in your biological profile, right? You have higher levels of antibodies, maybe, and it's just a guess on my part, maybe that was part of the secret sauce that enabled, however difficult these people to survive camp life better. So kind of influenced by Frankel, and I don't have time to introduce her at all. So I was deeply influenced by Dr. Rachel Remen, who wrote My Grandfather's Blessings and Kitchen Table Wisdom. We developed a 6-week program that kind of centered around logotherapy, cognitive behavioral therapy, positive psychology, mindfulness interventions, and a number of kind of process-oriented experiences. And so we developed this curriculum called that we call the GRACE program. And this is just an overview of the program that I'm not going to belabor right now. But the basic pearls that we go through is thinking about, however difficult it may be, meaning-centered living and trying to introduce strategies in which we can do this, trying to help our participants master a sense of perspective without being a Pollyanna about things, trying to integrate a sense of gratitude through gratitude journals and exercises, thinking about a sense of legacy, which means thinking about mortality. But that is one of the paradoxes that we dive into a fair amount. Is there are many that would argue that if we're going to live as well as we want to now, that we have to wrestle with the idea that all of us are mortal. And the importance, remember we talked about loneliness, the importance of staying connected and trying to create and foster community, mindfulness strategies, and again, strategies to try to integrate humor into our life. So we did this program for a while, and we finally realized we should put this to the test, and we were fortunate to get a grant to support a randomized clinical trial where we took women with metastatic breast cancer and enrolled them into the program, the intervention or waitlist control. And again, I was very fortunate to collaborate with Dr. Wertheimer and our chaplain Bronwyn Jones in running the program. And again, thankfully, without going through much detail, these are two common scales for quality of life: the facet spiritual scale and the FACT-G, which is an overall quality of life scale. And the higher you are, the better quality of life. And so what we found is compared to baseline, the group that went through the intervention had meaningful improvements that were maintained over time in both these parameters, and the control groups remained relatively flat. So one of the things that we realized we need to address, though, and this is a table from the study that we're actually submitting right now for publication, is when you look at the some of the detail, the vast majority, right, like 86 to 90% of our participants were white, and they were very well educated. And again, we still need to contend with the same basic idea of, how do we make these kind of programs more accessible to a more diverse group? How do we maybe translate this into other languages and make this more accessible? That's something that we do have to tackle on next, and certainly much more work needs to be done. Okay, and so I realize I'm getting close to 3:15, so I'm going to not discuss our improv program. It's on hold anyway because of the pandemic, because we can't do an in-person group-based program, which is really what you need to do improvisational comedy. But we hope we can relaunch this in the future. And I'm just going to round things out with just an overview of some of the programs that we have. We were lucky to have our exercise program that I mentioned. Yoga, we of course collaborate. We're lucky to collaborate with the cancer support community for Qigong. And I mentioned our GRACE program and our HAZE program. And like many others, we have an art therapy program, and more recently, we were able to launch a kind of cooking demonstration program. Our social work colleagues thankfully have started a sleep program and a mindfulness intervention. But I list all these things because it ultimately, in my mind, goes back to what I started with, which is, if you notice, none of these interventions, involve drugs. And I'm not saying that there's not a role for a medication, but again, going back to at least what is my personal bias, that the things that we think about on a consistent basis and our behaviors and our disciplined actions that we take on a day-to-day basis, I think in this space, in the cancer survivorship space, probably makes a more meaningful impact than whatever the drug du jour is. And so that at least is my bias. I'd love to entertain any feedback, comments, questions that you may have. And again, thank you so much to the cancer support community for inviting me and giving me this opportunity. Thank you.
Thank you so much, Dr. Asher. I mean, that was an amazing presentation. And I think what I'm going to remember from this, because it's so shocking, is that 3 years after cancer treatment, you can age 20 to 30 years in cardiac fitness, right? I mean, it was so shocking to know that number. And I think if more people, knew about it, like you said, if more providers spoke to their patients about the importance of physical activity, I think you would see more cancer patients moving, right? Because that is pretty shocking. And so my first question to you, Dr. Asher, is, exercise is one of those activities that's difficult to fit in, right? People say, I don't have the time. And it kind of sounds counterintuitive to say, I'm suffering from cancer fatigue and you're expecting me to move, but I'm too tired. So, but it's also one of those things where you can see the immediate results and feel better, right? Immediately. So what do you say to those patients who say, you know what, the fatigue is too much. And, I have, a million things to do. I'm taking care of my family. Maybe I went back to work. How do I make sure I make physical activity a part of my daily life?
That's a great question. And I kind of think about that in a practical level and, maybe just a more kind of philosophical level. So on the practical level, I think it's really important to have some kind of structure because, right, when somebody's so profoundly tired and somebody is just telling them to get some exercise, that could almost be insulting to that individual. And so one of the reasons why, whether it's a physical therapist that's experienced in working cancer survivors, or if you have access to a structured type of program like we mentioned in our exercise program, is when somebody is there to assess where you are at baseline. Right, and let me explain things this way. So I'm going to take a step back. This is going to take a second, but I think it's important. If you look at the recommendations that we talked about, it said 150 minutes a week of moderate aerobic exercise. Now, what's moderate, right? Because what's moderate for like an Olympic athlete and what's moderate for Mr. Jones is going to be two totally different things. And so one of the things that happens is people hear that thing, get 150 minutes of exercise, and they'll say to themselves, okay, I used to, I'm just making this up, jog 3 miles 3 times a week, and it was very moderate for me. And I'm going to try to go back to my previous regimen. But what used to be moderate for me before the surgery, chemo, and radiation today may feel like training for a marathon, which is going to probably make you feel worse and more tired and more aching and whatnot. So resetting what is moderate today is what we need some guidance on. And that's where our trainers and exercise physiologists can really help guide so that it becomes more gentle. The other part I would just say is it's having some kind of accountability with whether it's a friend, a neighbor, a group, a class, a trainer, that really makes a big difference. It's really hard to start this unless you're incredibly disciplined, which some people are, but I would argue many of us have a harder time. However way we could facilitate that accountability, I think, is half the battle.
Yeah, the who keeps me accountable is my 2-year-old puppy. Because if I do not walk her every day, she will make my life miserable and will not let me work. So, it's a huge motivator for me to get moving. And I know the other thing I did is I put my Peloton in the living room. So it's a constant reminder. So the days I feel like a couch potato, in the corner of my eye, I can see my Peloton. I'm like, ooh, I kind of should be moving, right? So thank you for talking about that. And, the difference in terms of, like you were saying, moderate exercise, and it's really your rate of perceived exertion, right? At what level? And so I love that you're mentioning that, because I think all of us think we should be working to the point where we can't breathe, where, you're about to faint, you're sweating like a marathon runner. So thank you for really, bringing that up. I think it's a great reminder.
And I would just say, just really briefly, if your patient is trying to grapple with that, pragmatically, what that means is, if you can sing a song, the whole time, you have some room to maybe increase the intensity. But if you cannot speak in a sentence because you're huffing and puffing, then you are in the intense zone, and we can slow that pace back. So moderate means you should be able to talk in a brief sentence, and that could serve as a kind of practical guide.
Oh, that's wonderful. Thank you. And we have a question from one of our attendees. They're asking, what are the benefits, if any, of receiving speech and language therapy from speech-language pathologists for chemobrain? Great question.
So the program I mentioned, Emerging from the Haze, is obviously a group program. It's not tailored, right? And we know that when, for example, a patient with these cognitive symptoms maybe has neuropsych testing, a neuropsychologist will delineate how someone is doing in terms of their attention and processing speed and visual memory and other aspects of cognition. And so I think a speech therapist would be an ideal partner to tailor that kind of rehabilitation based on that individual's strengths and weaknesses. And of course, they have the advantage of working one-on-one with a person on their goals in a way that we can't offer in a group type program. So I'm glad somebody brought that up. I love to use our speech language pathology colleagues, and it's made a big impact. And again, people hear the word speech therapy, our lay community, and they don't realize that a big part of their role is offering cognitive rehabilitation strategies.
Yeah, taking advantage of all the services that are available, right? Something we're not used to seeing as part of our care team. And I think that's a great question. So whoever posted that. Now, our next question, Dr. Asher, is, to what degree are patients you work with open to the posture of, what does life expect from me?
So that's a really hard one. And I didn't really mention this when I was mentioning our GRACE program. We try to be very careful about, as best as we can, in who we invite, because let's face it, many individuals just don't want to go there. Maybe they shouldn't go there. It might be too triggering, and the wound may be too raw. We usually, as a general rule, tell individuals that if you were just diagnosed within the last 6 months, you should not consider this program, because again, it's too raw to be thinking about these things. But then on the other hand, I think there are a number of individuals who have gone through this life-changing diagnosis. They may have overcome many of the physical challenges, but that existential piece is still something that they want to wrestle with. And if we could try to figure out, who is that subset of individuals that is really interested and maybe has the introspection of wanting to contend with these really more profound ideas. I think in my experience, for those individuals, when you expose them to these ideas, it could be profound in terms of how much of a shift it can offer, and again, how we're seeing our world, how we're perceiving our relationships and the important things in our life.
Thank you. And one other question I have, and I know you brought up, it's all the things that are affected by cancer treatment or just the cancer diagnosis, and you brought up things like DNA methylation. And I know some of the recent studies are also showing that for some survivors, the treatment is also causing insulin resistance, right? And so some of the patients are gaining weight, and so they're looking for ways to be physically active to combat that. So I was wondering if you could if you could speak a little bit more about that with people who are, we're telling patients, try to maintain a healthy weight to prevent the recurrence and move. And so now there's something else they have to contend with, and sometimes it's this insulin resistance.
It's a big challenge because sometimes the hormonal drugs that individuals have to take for a number of years may be contributing to that. And it's not something that is advisable to stop. I didn't spend much time talking about this. I do think aerobic exercise is important for insulin resistance. I'm believing more and more as I dive into this topic that learning to lift heavy things, when I say heavy, heavy for you, right? I don't want anyone to hurt themselves or make sure that we don't have poor form, but really developing muscle mass my favorites are the squat, the deadlift, military lift. I know historically all of the attention has gone on just aerobic exercise, but developing muscle mass seems to be another important mechanism for insulin resistance, number one. Number two, and again, I would never advise anyone to do this on their own without making sure they have appropriate supervision or clearance. I believe now that all of us, but especially for people that are trying to address insulin resistance, should sprint every 7 to 10 days. And again, there is a learning process in how to sprint safely. And whether the sprinting is in the pool or on a bike or on a rowing machine or on land, and making sure the form and the mechanics and the warm up and the cool down. But it seems that doing this for 20 seconds where you're at 90% or 100%, if it's safe for you, seems to activate, again, a different part of our metabolism that I think is really important for metabolism and insulin resistance. So bottom line, there is a lot of research going on in the exercise physiology arena and how it relates to cancer outcomes. And I think that's really one of the exciting areas of cancer supportive care is the great work that people are doing and really teasing out, rather than just saying exercise, who should be doing interval training, sprinting, weight training, balance work, the combination, how much of each. I think there's going to be much more guidance in the coming year.
Yeah, thank you. I think a lot of us tend to kind of have a bit of fear with strength training, right? We think of, lifting weights as something you have to do with big, heavy weights. And, I love, I have 2-pound weights, 3-pound weights. I, try to do different ones, but sometimes, even those resistance bands, right? Or like you were saying, just using your body weight, like squats. And I mean, my least favorite friend, burpees and bear crawls, right? All of those are helping to strengthen that muscle mass and helping with all that. So thank you for talking about that. And I know we're close to the end, but I wanted to squeeze in this one last question for you, Dr. Asher. And this one says, can you speak to the difference, if any, between depression and anxiety as a response to the cancer diagnosis versus driven by metabolic flooding in the brain due to chemotherapy?
So that's a great question. I don't think I'm going to have an easy answer, but one of the things that has been hypothesized for some time is the chemotherapy triggers an inflammatory response, things like IL-1, IL-16, alpha. And if you think about, for example, the anecdote I often share is if you think about how any one of us feel when you have the flu, right? If you think about it, most of us when we have the flu, not only are we tired and a little foggy, but we're kind of sad or blue and depressed, at least for those few days. And it's not the flu virus that makes you feel so crummy and sad. It's your body's inflammatory response, right? IL-1, IL-16, alpha, these inflammatory compounds that can cross the blood-brain barrier, get into our brains and contribute to those symptoms of depression. And I believe that may be an important factor for a subset of our patients, that they have this, this inflammatory response magnified due to their treatment. And again, one of the reasons, that I think exercise can help, not only help with fatigue, but help with depression and anxiety, is because it can reduce those inflammatory cytokines. When your muscles contract, it produces these things called myokines, which then reduce the inflammatory cytokines. And again, I'm not saying that there's not a role for medications, but I've seen it over and over again. When you get someone more fit, symptoms of depression, anxiety, and self-efficacy, as we talked about, all improve as well, usually.
Well, thank you so much, Dr. Asher, for that wonderful information. And I know it's a nice little reminder for me to get moving today. I have not taken my dog for a walk today, being here at the farm, but she will get walked later today, and so will I. So thank you for that wonderful information. And I want to thank all of our panelists today and our speakers. I want to thank Bill Kavanagh. I want to thank Dr. Jennifer Kelly and Dr. Shannon Cava. I also want to thank our roundtable panelists. I want to thank Sylvia Lopez, Dr. Shannon Cava, Rhonda Smith, and Ghecemy Lopez, and as well as Dr. Whitacre for joining us today, and our speaker, Dr. Asher. And we hope that you all learned something new today and, are going to take this into, now we're building this awareness for you that you're learning all of these things, and we hope you take them to action, put them into practice in the future. And we hope you join us tomorrow. Please join us tomorrow. We will be here for day 2, bright and early at 9 a.m. And we have another wonderful roster of speakers waiting for us tomorrow and another roundtable. So thank you for joining day 1. And, again, be on the lookout for that email for those of you who wanted CE units. And then we hope to see you all again tomorrow. Thank you all very much and have a wonderful afternoon. And don't forget to move, like Dr. Asher was telling us. Move a little today. Thank you, everyone.
Thank you very much.